এই মাইকটা অন নেই। Hello. Yes.
Yeah, ma'am, can you share my presentation again? Because that is not that disappear from the screen.
Yeah. The make his presentation full screen.
Okay.
Such a
Good morning to all. Now I request Professor Dr. Narayan Prasad, Head of the Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, to deliver his lecture on this topic, renal genetics and kidney transplantation.
meeting শুরু হয়ে গেছে, পরে কথা বলবো। Text করে।
Okay. Can I proceed now?
Yeah, sure, Narayan.
Yeah. But still, it is not full view, ma'am. Can he make a full view?
Yes, sure.
It again disappear.
Presentation is done. Presentation.
Screen again disappeared, ma'am.
Can't share screen. স্মিতার ক্ষেত্রেও তাই হবে।
So now I see, ma'am.
Yes.
So should I start?
Yeah.
Someone will move slides from your end, ma'am, because this is not moving from my end. So someone will
You
move.
go there and move search slide. আপনি ছেড়ে দিন।
So, good morning, everybody. Particularly Dr. Devashish Banerjee, great friend again back to India, Kolkata. So, thank you, everybody. Thank you all representative from ISN and TTS there. So, basically, I have been given the task to speak on renal genetics. So, we all understand that is how important it is in today's era. What does a patient expect to know from a physician? What disease did I acquire? They want to know the diagnosis. Why did it happen to me? Why did you give me these medicines? Will I recover? So is this possible to answer this question precisely only on the clinical grounds? Answer is clearly no. Can you move this slide? Move slide, please.
Next slide.
Answer is clearly no. So, in a human genome project that I'm giving you a brief on how it evolved, it started in 1990 and completed in 2003 with a focus on identifying, mapping, sequencing all genes in the human genome. And it becomes 100% complete gap-free only 3 years before in 2022, and approximately 3 billion chemical base pairs of the human DNA has been mapped. We can just wonder approximately 20,000 of protein coding genes are in human genome. Most are identical among couples. So this is the reason why all humans looks like the human beings. And only slight variations cause some phenotypic changes. So that why I am Narayan Prasad, why this is Devashish Banerjee and someone else. It also contains other non-coding RNA genes and pseudogenes and inactive copies of the genes, but are important for understanding evolutions. Next slide, please. So, foundation work on DNA sequencing that basically started with the discovery of the Felix Sanger's. Sanger's sequencing, we all understand, that was started in 1970. But that was a very long time taking process. So since then it evolved, targeted strategy came in 2005. In 2009 was the very good era for the genomic exome sequencing project was pioneered in 2009. Then in 2009, whole exome sequencing was formally developed by NG and colleagues. And this was the year, the first time this whole exome sequencing came into the practice, and the first patient who was misdiagnosed with the Bartter syndrome actually has the congenital chloride losing diarrhea. We all understand these patients have the similar kind of the phenotype, hypokalemia, metabolic alkalosis, and so this was basically chloride losing diarrhea, and which was misdiagnosed. That was the first time when the first clinical diagnosis, first clinical use of the exome sequencing. Next slide, please. Next slide. So, genomic, pharmacogenomic, and precision medicines that we all see the key achievement of this project was the free and open release of this genomic data to the public, fostering a new era of the data sharing in biomedical research. This is all freely available. Those who knows about the bioinformatics can go and make a multiple research out of this data. Genomics is used to diagnose kidney diseases. Pharmacogenomics helps in tailoring medication selections and dosing, and precision medicine an approach that tailors disease treatment and prevents an individual's unique characteristics, considering their genetics, environment, and lifestyle altogether. Next slide, please. So, how is genomics and pharmacogenomics applied? Genomics, diagnosis of the genomic kidney diseases, disease risk assessment, prognosis, and family screening. Pharmacogenomics, particularly used for optimizing drug selections with genetic variants, personalizing the dosings, and reducing many adverse effects of the drugs. So, in December, on December 18th, 2015, Barack Obama launched a bipartisan precision medicine initiatives. And that was the turning point for the work of this genomic and pharmacogenomics in precision medicines. And the theme was to delivering the right treatments at the right time, every time to the right person. And NIH was at the forefront of these initiatives, helped to drive participants engaged data-driven research with the combination of the data on the biology, computation, medicine, genetics, and environmental knowledge all together. So, precision medicine initiative was then, now it is popularly known as All of Us Research Program. Initial cohort included about the cohort of the 1 million participants, their health information and samples into the national database and biobankings. And all of us research project become so popular, and it exceeded this 1,000 genomic project, and Genomics England, so the 1 lakh genomes project in scale and scope. That becomes very popular. So, sub-aim of this precision nephrology was the database approach. You have the information on the traditional clinical data, then transcriptomic data, metabolomic data, and metagenomic data. We can just imagine it was not possible to identify all microorganisms in your gut microbiota. This was all this evolution of the metagenomics, which made identify all different kind of the microbiota. Next slide, please. So, using genomics and pharmacogenomics, you can see one size fits all model was the current treatment scenario, which usually the most of this us sitting in clinics need to do this. We gives the particular same treatment to almost all. Some has minimal toxicity and gets success, has excessive toxicity, some has full failure. So then next slide, please. Next slide. Go on clicking it. So when you have the excessive toxicity, go back. Just go back. When you have excessive toxicity, treat with the alternative dose. When you have the failure, you can treat with the alternative drugs or dose. When you have full failure, the patient has the excessive toxicity and the failure same times, treat with the alternative drugs. So this is all about the precision medicines. Next slide. So I'm giving you some examples of the patient. This was uh, one patient, 26-year-old at SGPGIMS came with this oculocutaneous albinism. You can see from the figures. Just give one click more so that this video will run. Just one click. Yeah. Okay. If it is not running, no issue. So this patient had nephrotic syndrome at 12 years. Go back. At 12 years of the age, treated by the local pediatricians with several cycles of steroids, CNI, mycophenolate mofetil for 10 years without any response. He presented to us with a steroid-assisted nephrotic syndrome with biopsy findings showing minimal change disease with possible FSGS. Patient had uncontrolled hypertension, has nystagmus, oculocutaneous albinism, sensorineural hearing defect, anterior lenticonus. Next slide, please. So what we have then we have run the biopsy. After that, he de- yeah, yeah, just, he developed a hearing defect, sensorineural loss by the age of the 15 years, declared ESRD. Patient has been shifted on maintenance dialysis, and you can see her electron microscopy was very much suggestive of uh, Alport syndromes. Next slide. So his brother was again the 26-year-old. This was the twin brothers, oculocutaneous albinisms. Next slide, next please. So no complaints of hearing loss before presentation. He was doing well and came to the ward to see his brother. He was totally asymptomatic. He came to meet his brother, and his mother had just told me that he has little headache. So you can see here, this is the inheritance pedigree chart. These are the two twin brothers, and one was already admitted, other came to see this his brothers. Next slide, please. So he was this is the story of his brother. He was otherwise asymptomatic. We tested him in the ward. He had hypertension, subnephrotic proteinuria, anemia, advanced kidney failure, bilateral small kidney on ultrasonogram, anterior lenticonus, advised conservative treatment on follow-up, and he also developed ESKD and opted for kidney transplantation. Next slide. So we have evaluated his parents also. Both were carriers. Here you can see, and on the genetic testing, what you can see, this patient has the defect in the tyrosinase gene, which is responsible for formation of the melanin or pigmentation. So this was very much pathogenic in this case, and toll for A3 was also there, and this electron microscopy and other phenotype was also very much suggestive of the Alport syndromes. So there was no confusion. It was coming as a VUS, but we are very certain that this is pathogenic gene and the patient has Alport syndromes also. Next slide. So both SK and RK, both brothers, when we have started workup for the transplantation. One was for the ABO compatible transplantation with father as a prospective donor. We all understand mothers are usually the carrier in this scenario. This is X-linked derives. So father was the T cell cross match was negative, B cell cross match was negative, but there was some single antigen build assay. You can see some of MFI agents, some of this donor specific antibody. You can see here MFI was quite high. RK has also worked out. Subsequently, we tested the mother. She has no any proteinuria, no any macroscopic hematuria. She was normotensive, so no abnormalities. So that is usually we used to take such a mother of Alport syndromes as a donor. We have tested for DSA by lygates, that was all negatives. Next slide, please. So, Alport Syndrome Foundation and other experts recommend that you can take mother as a donor if there is no proteinuria, normal hearing, normal kidney functions. Advances usually more than 45 years or older females, and a biopsy sometimes should be done to see the kidney damage, but usually we do not do in the practice. Comprehensive genetic testing to confirm the diagnosis, and thorough counselings for all potential risks to the donor and recipient. Both underwent transplantation. First SK, first brother, transplanted on with the father on 31st of January 2024. Induction was antithymocytoglobulin. There was some, you can see, the patient had some antibodies. So antithymocytoglobulin, some plasma exchange has been done. Desensitization protocol, what we follow at our place, has been done, and the patient has been transplanted. The other, after some gap of the 5 6 months, mother came out for the second sperm. Again, we have transplanted with this basiliximab inductions. Next, next slide, please. Here we can see this family, Alports plus albinisms, oculocutaneous albinism in both brothers. Parents were totally normal. Rare instance of the two genetic variants causing two different mode 4A3 and plus tyrosinase gene was affected in this uh, in brothers. So lesson learned from this case study was early genotyping study. If we could have done when the patient was steroid resistant, we could have avoided multiple immunosuppressions and their side effects in these patients. The genetic study provided confidence that probably if you have this genetically positive uh, steroid assistant nephrotic syndrome, the chances of recurrence of the FSGS is minimal after transplantation. So that confidence also considered. Another, next slide, please. Another boy, 12-year-old boy with a steroid-dependent nephrotic syndrome. Again, we can see. Give a click on photographs. Again, this boy also has nephrotic syndrome. Initially, steroid dependent. Subsequently, we have seen there was a lot, lot many cycles of the steroid CNI rituximab has been given for this nephrotic syndrome. Patient had nystagmus. Family histories. Patient's elder brother died of the kidney disease, but nobody was knowing why this died. So, so we have planned for some genetic workup. Next slide, please. So here we can see the one brother died, this brother was affected, and what we can see, there was mutation in the LAMP2. And we all understand this LAMP2 is associated with the nephrotic syndrome and autosomal recessive. Uh, Usually, the autosomal recessive patterns are usually seen. So here again we can see, next slide, please. So we have made this patient diagnosis of the Pearson syndrome, but it was not very typical of the Pearson syndromes. So sometimes the phenotype may be different. So human mutation in laminin B2 has been described with this LAMP2 mutations. It is characterized by neonatal nephrotic syndromes, eye defects, macroporia, abnormalities of the neuromuscular junctions. But this boy has nothing. Go ahead. He presented late. Usually, usual onset is age of 4 years. No macroporia, no. But this child has a nystagmus. Yes, no neuromuscular involvement. So usually this phenotype was a little different. So next slide. So a total of the 680, I'm just giving you one recently data we have published in our CKJ this year. A total of 680 pediatric nephrotic syndrome patients which were at follow-up at IPGMER. We have got tested for the steroid assisted nephrotic syndrome and some genetic testing has been done. Amongst the participants, back 64% have reportable genetic variants, and most common amongst the nephrotic syndrome, you can just imagine all 4A genes. So it appears that the Alport syndromes in Indian scenario, you have, if you have the steroid assisted nephrotic syndromes, And even if at initial stages there is no lentitonus, no hearing defect, but if you are going to test for the genetic test, this collagen genes turns out to be positives. So this was a major finding in our study. And we have also seen many of these patients when you are putting on the CNI, they have either partial or complete remissions with the many of the other genes mutations also. So it is not that if the genetic mutations are there, you should not try. We can try with the CNI. Some patients, we all understand there is some cytoskeletal stabilization with the CNI and can reduce to some degree of the proteinuria. So this was the finding from our study. Next slide, please. And you can see we have also divided into the different inheritance pattern of this mobile mutation in steroid deficient nephrotic syndrome, autosomal dominant, autosomal recessive. What was this peculiar finding, which is commonly reported in other studies by NPHS1 or 2 genes? That was the rare finding. Only 2% of the NPHS1 and 2 was there in our whole of this cohort. So it is looking like it might be the uncommon finding in Indian scenario. And this finding has been reported. Similar kind of this observation has been seen in AIMS data and data from the St. John's, Bangalore. Also. Next, next slide. I'm giving you one example of the adult nephrotic syndrome. This was 46 years male, hypertension for 3 years, bilateral pedal edema, polyurine. Again, there was no confusion in the patient probably had nephrotic syndrome. Next slide. So 24-hour urinary protein was 9 gram per day, and you can see protein albumin was low. So we thought that we should go for the biopsy. Next slide, please. And next slide. So biopsy showed FSGS, kind of the pictures. This was globally sclerosed by this time out of 14. And there was some foamy appearance, and there was some moderate kind of the interstitial fibrosis and tubular atrophy also, and no immune deposit. So looking like this, it is a FSGS. Go ahead. Next slide. But look at this disease chart. This was very wonderful patients came from Mumbai to us, and you can see the lower chart. One ESRD with biopsy was not done. This was biopsy A, but WT1 gene mutation was there. Second one, CKD stage 3B, biopsy has been done somewhere else, but that was diagnosed as IgA nephropathy, but subsequently WT1 genes. Third one, horseshoe kidney, nephrotic syndrome, CKD, 5 WT1 gene again positives. And this index case, 46 years ESRD patient, biopsy was showing FSGS, WT1 gene again. And other 26 years had CKD. So you can just imagine there are different phenotypic variations. One has a horseshoe kidney, other was showing some IgA nephropathy. All were common steroid-assisted nephrotic syndrome, and with this WT1 gene mutations were there. Next slide, please. So we have got the genetic testings. This gentleman has also WT1 gene mutation, likely pathogenic. Next slide. So diagnosed as FSGS with moderate IFTA, no response to the features of the steroid toxicity, CNI, multiple CNI, tacrolimus, and many other drugs has been received. But patient was progressively land up in the ESRD within 1 year, and patient is being planned for transplantation. But this genetic testing again give us confidence that probably there will not be any recurrence in this FSGS kind of. So WT1 genes is Williams tumor suppressor gene. We all understand. I'm not going into the depth. Uh, so clinical manifestations of WT1 gene, you might have the different manifestations. We all understand from our MBBS days, it is associated with the Williams tumor. It can have the Frazier syndromes, Dennis-Drass syndromes, disorders in genital development, and isolated WT1 nephropathy, steroid-assisted nephropathy syndrome can also be seen. What was there in that index case? So WT1 genes, even in adults, sometimes If the patient is not showing the typical codes, we should investigate this for the genetic testings, and we can find out some of the genes involved in causing this disease. That gives you the confidence that probably you are dealing with this, going ahead with this right directions. Next slide, please. So genetics in CKD indicates that family history is there, consanguinity is there, extrarenal manifestations are there, dysmorphic or syndromic features are there, CKD of unknown etiology, cystic kidney disease at very younger age. Also, some of the centers doing this genetic testing, acquired cystic nephrotic syndrome, childhood onset of the CKD, lot many indications are there now. There we need to go into the depth to see, make the native diagnosis, native kidney disease diagnosis. Next slide, please. So clinical implication of the genetic testing is the direct diagnostic implications, implication of ongoing treatment, and implication for kidney transplantation. Next slide. So genotyping and phenotypic assessment pre-transplantation. I'm just giving you example. A 30-year-old male had proteinuria of 2.8 gram, active urine sediment, proteinuria of 3 plus, RBC of 8 to 10, serum creatinine of 2.8, normal C3, C4 levels, ultrasonogram. As usual, the patient presents late, usually borderline less than 9 centimeter, increased echogenicity, CMD lost. Patient informed for the need of the kidney biopsy and associated risk. He refused kidney biopsy, and the kidney size is also borderline. Empirically, prednisolone MF has started its ESRD in 3 years, is now for the kidney transplantation. Provisional diagnosis was IgA nephropathy FSGS. Very typically made a diagnosis clinically. Next slide, please. So genetic testing for the native kidney disease, ESKD of unknown etiology, early onset ESKD, family history of ESKD, and extrarenal manifestations are there. These are the common. Next slide, please. Atypical hemolytic uremic syndrome, primary hyperoxaluria, FSGS, ADPKD, EPOL1 genes. That EPOL1 genes are usually may not be required in Indian scenario because the data from PGI Chandigarh, data from Madras Medical College, and even we have initially seen our big series of the sample. We did not find any EPOL1 gene mutation in India. So that is now very known fact that probably this is not in Indian scenario. Next slide, please. So why do we need a pre-transplant immunogenetic workup? So I'm going a little bit about this further transplantation. Compatibility assessment, risk stratifications, treatment planning, and finally the patient selections. Next slide. So HLA testing for the kidney transplantation, usually we all understand by the August 2025, more than 42,000 classical HLA class 1 and class 2 alleles have been discovered. HLA might be someone else might be also taking on the class of this year. We know about the class 1 and class 2. We know about the epitopes on the HLA class 1 and class 2 both. Usually class 1 has three chains alpha 1, 2, and 3, and beta 2 microglobulins. And in class 2, we have alpha 1, 2, alpha 1, alpha 2, and beta 1, beta 2. And the epitope is the place where antibody used to come and bind. So we should know that this is the epitope, and those antibody which used to come and bind this groove in the peptide binding grooves. So that on the antibody side is called paratope, and this is called epitopes, just for the postgraduates. Next slide, please. So usually the nomenclature of the HLA that has been came into the picture in 2010 by WHO, where HLA, and it comes up. A is the gene, and then separation is used, and then allele, then specific proteins, then coding sequences, then non-coding sequences. And what is important to understand in HLA matching, which we used to do in clinical practice, that this father and mother HLAs are there. They comes in the set from the one set from the father, another set from the mother. Here, for the example, father A1B8 and DR17 from the mother. This is A2 44 and DR4. So this inheritance comes in a set. So that helps you in day-to-day practice in matching whether this parents HLA is matching or this. Next. So usually reportings of many times we are confused with these digits of the two digits reports, single digits reports. Two-digit reports is very common, and that two-digit reports include alleles, four-digit reports a specific HLA protein, six-digit reports a specific HLA coding sequences, eight-digit includes a specific HLA genome sequence, including ultra-translated regions and some of the introns also. So usually in kidney transplantation programs, up to the two-digit alleles, it is fine, and we do not have this required intermediate resolutions is good enough. High resolutions is usually required. If it is available, it is very good. If it is not available, then many of the centers in India do not follow this high resolution by NGS with all four digits, but two digits are fine for this for kidney transplantation programs. Next. So we all understand that as soon as your mismatches go down, the survival go down. Next slide, please. So risk stratifications is very important for us. It is looking at the history, at the blood transfusion, pregnancy, and repeat transplantation. Those who are involved in heart transplantation. So this is the one extra point, whether it's prior exposure to tissue graft or left ventricular assist device. That is also a risk factors, because in Kolkata there are multiple centers are doing heart transplantation also. So that is another important point to understand that. So next slide, please. So integrating HLA typing in risk assessment is very important. I'm giving you this here. We can see the wide spectrum. At the one end on the right side, high titer DSA, flow cross-match positive, CDC cross-match positive. There is a very high risk of the acute rejections. As soon as you go down towards the blue line, the risk when there is no HLA antibody, if you have this single antigen bead assessment or PRA done, there is no HLA antibody, risk for de novo response that becomes the main one. And if it is HLA identical, which is very rare in in our scenario, then there is very low risk for any autoimmune disease or chance of the rejections. So usually we have this spectrum of the testing now. So flow cytometric cross match, CDC cross match, then single antigen bead assessment, and then most of these high volume centers, these are all available, including at our centers, and then we can mix and match for the risk assessment. Next. So yeah. So we have cross-match before transplantation, single antigen bead testing, flow cytometric cross-match, and CDC cross-match. Usually we used to get it done. And when you have this highest sensitivity is there with this single antigen bead testing, and flow cytometric cross-match high, and the lowest sensitivity is there with the CDC cross-match, and all identify anti-HLA antibody. So but definitely we all understand I don't have the time too much to go into the depth of this um, detail of this different matching or finding of this NTHLA. Sometime else or someone else might discuss on these topics. Yes. So here comes, if you have all three positives, there is no confusion. There is significant burden of the DSA, donor specific antibody, and high risk for hyperacute rejection. Confusion comes when one is negative, like the CDC is negative and your flow and SAB is positive. Then definitely you have this moderate burden of the donor specific antibody, and some non-complement fixing antibody, it is quite possible. Complement fixing you can only test on CDC. That is not tested on the flow and SAP. So probably it is possible that some non-complement fixing DSA is there. If only SAB is positive, flow and CDC are negatives, then you can think of there is the lowest burden of the donor specific antibody. And false positive SAB can also be there due to some high background serum factors binding to latex base, binding to denatured antigen, O threshold for calling in antibodies, and sometimes different serum used for the SAB versus cross match testings. Sometimes it happens that in the laboratory, serum which has been sent for testing for the CDC was different and for the SAB was different. It is also quite possible because you test it at different point of the time. So everything should be kept in mind, but because the sensitivity of the SAB is very high, but CDC has the low sensitivity. But they detect the advantage of the CDC is you get by CD complement fixing DSA antibody. Next slide, please. So it is quite possible that sometimes SAB negative, but flow and CDC is positive. So again, now the one of the new emerging factors are the non-HLA immunoglobulins binding on the surface of the lymphocytes, non-HLA antibody. So that you, if you have the facility, you can test for. Recently, we have tested in our lab, but this was very much discouraging. A lot of anti-HLA antibody we have detected in our staffs. When we have tested it, that really what we are going to do this, we have tested the patient who has rejection. Some of the patients do not have the rejection, and some we have as a control, negative control tested in our lab, but that was non-specifically very high in some of our staffs, normal healthy persons. So I do not know how to interpret this in the future. Next slide, please. So steps for immunological workup usually ABO typing, HLA typing, antibody screening, cross-match test, donor-specific antibody identification, finally transplantation and outcomes. Next slide, please. This is my final slide. So this is my request. IPGMER is organizing ISN 2025 this year at Lucknow from 18th to 21st December. So I will welcome you all to register yourself, and if you are willing, if you have any problem in getting the registration or any accommodation or any problems, let me know. I will try to resolve it. So thank you, ladies and gentlemen. Thank you for this opportunity. Thank you, Arpita ma'am, and all members of this Kolkata. Thank you.
Thank you, Dr. Narayan Prasad, for an excellent lecture on genetics and its implications, and for the precision medicines that comes with it. If any students have got any queries or questions, is there any questions or comments? So, thank you, Dr. Prasad. There is no questions or any comments from the floor.
Thank you.
Close this session. Okay.
Naren, I have a few, but I'm not bothering you now. You will have to catch a flight. So we will meet in ISOT and I will resolve.
Okay, ma'am. Thank you.
Hello. Our next speaker is Dr. Smita Dibbabir. He is the Associate Professor of Nephrology, IPGMER Chandigarh. She is our ex-resident and brilliant resident. And now I request her to speak on her topic, hepatorenal acute kidney injury. Welcome.
Thank you.
Okay. Am I audible to everyone? Okay. Shall I share my screen from here, or somebody will be projecting the slides?
You are finding the share button there?
Yes, I have shared now. I have
And you
shared.
can share? Then you can share it from your end. It would be smooth to glide.
Yes, yes, I'll be able to change my slides myself.
Yeah.
Okay. So, are my slides visible? Should I start?
Yeah, sure, sure. It's visible.
Yeah. Very good morning to everyone in Kolkata. Greetings from Chandigarh. It is always great to join Calcutta, my alma mater, and it's a pleasure to see my teachers. At the outset, I would like to thank the International Society of Nephrology, the Transplantation Society, and my alma mater, IPGMER, for giving me this opportunity to share my thoughts and words on hepatorenal AKI, a topic of my keen interest. So this shall be the outline of my talk. I will speak on AKI on cirrhosis first, its importance and how the various definitions of AKI have evolved over time. A little bit in brief about its pathophysiology, what are the management strategies in AKI? We shall look at the prognosis. And then one of the most critical things in this talk shall be how do we decide on simultaneous liver kidney transplant versus doing the liver transplant alone? And finally, how accurate are the assessment methods for renal function that we currently have? And what is the role of biomarkers? So, as we all know, renal dysfunction is defined by its duration. Any injury that is occurring within 7 days is what we call an AKI. Its severity decides its stages. If it is something between 7 days to 3 months, it is an acute kidney disease, and anything more than 3 months is a chronic kidney disease. A similar spectrum applies to cirrhosis. So, cirrhosis is essentially a chronic liver disease, and yeah, it can go through various phases where it can remain compensated for some time, and the patients may experience decompensation as they go down. And the first decompensation itself portends a bad prognosis with a median survival of just about 1 or 2 years. Uh, in CKD, in cases of compensated cirrhosis, in certain cases where the cause is hepatitis C, there may also be a regression of cirrhosis. So, this understanding is essential that the stage of cirrhosis and the progression of cirrhosis, along with superimposed acute and chronic liver failures, will decide the eventual course and the risk of kidney injury occurring in the setting of cirrhosis. So let us look at why this renal function particularly is important in this setting. Whenever an acute kidney injury happens in cirrhosis, it increases mortality not just in hospital during the same admission, but also at 30 days, 90 days, and even up to 1 year post the episode of cirrhosis. Moreover, the stage of AKI is also associated with the risk of mortality. Higher the stage of AKI, more is the risk of mortality. So, if someone had a stage 3 AKI, almost 70% of such patients will not survive up to 5 years. So, AKI is of extreme importance in cirrhosis. How do we define AKI in cirrhosis and how different it is from the other settings? So we know very well that the initial uniformly accepted criteria was Rifle in 2002, and this Rifle criteria gave a kind of severity of AKI along with two stages. Here, there was a baseline AKI, and the increases in creatinine over that baseline were used to define the stages of AKI. The problem with this was that many times baseline is not available. The other thing is that Rifle took the duration of 7 days as a cutoff to call something an AKI. So clearly, it was soon realized that we need earlier recognition of AKI to institute corrective measures. So the AKIN in 2004 revised this, and the changes over 48 hours, as early as 48 hours in creatinine, could diagnose an AKI. In addition, because a baseline may not be present, so any increment of only zero point 0.3 over happening over 48 hours is enough to call something an AKI. So we all know this is how methodology calls how it has defined AKI. HRS, however, has had its own journey. In 2007, the International Club of Ascites gave the definition of the hepatorenal syndrome as something where the creatinine, as a condition where the creatinine is more than 1.5. It is an absolute level. And it required 48 hours to make this diagnosis after diuretics were taken off and then resuscitation was done. It required the absence of shock or alternative causes of acute kidney injury. So it had defined it into two types, type 1 and type 2. So type 1 was when the creatinine rose to more than 2.5 in less than 2 weeks, and 2 was a more slower course and a more indolent one. Now, the definition of AKI has, in 2012, been given by KDIGO along with the Acute Disease Quality Initiative as something that incorporated all the changes of the definitions before that. In addition to the urine output criteria, the creatinine criteria is similar to what was given by AKI. So ICA took some time. So after 2012, the HRS was still being defined in a different way until 2015, where the definition given by KDIGO was adopted, especially the part which dealt with serum creatinine changes. The urine output was yet not incorporated. In 2019, it was realized that although these patients are on diuretics and some of them may have reduced urine output compared to the other settings, the presence of oliguria portends bad prognosis. So urine output criteria was also taken in 2019. So one must remember that even now, the HRS AKI remains a diagnosis of exclusion. There should not be a presence of any shock, history of any nephrotoxic drug exposure, or any evidence of structural kidney damage, which could be in the form of an ultrasound change, or finding urinary sediments, or significant proteinuria. So this is how the old and the new terms stand now. We don't call an HRS type 1 as HRS type 1, but instead it has become an HRS AKI. The type 2 is HRS CKD, and CKD in the setting of cirrhosis is HRS. Now, the categories or the types of AKI as defined by the compartment of the kidney affected is more or less similar to other settings. That is, we have a pre-renal AKI, an extreme form of which is HRS AKI, the intrinsic renal and the post-renal AKI. Some peculiar things that occur in cirrhosis can be IgA nephropathy, secondary IgA nephropathy, or hepatitis B C related GNs, or bile count nephropathy. Other than this, the commoner causes like ischemic injury or toxic injury are also common causes of AKI in cirrhosis. So this is just to elaborate a little further that within the prerenal causes, in the setting of cirrhosis, laxatives and diuretics are often used, and they can predispose to a prerenal AKI. Another thing peculiar is the presence of renal vein congestion, which can be present in the setting of massive ascites or a tense ascites, and the presence of portal hypertension and cardiomyopathy may also contribute to renal vein congestion. Although rare, one must be aware that midodrine can induce some kind of crystalluria, and these crystals can obstruct the excretory system, contributing to obstructive urine. Now, whenever we need to define the renal function in cirrhosis, cystatin C is one other thing that needs to be considered, because KDIGO, the latest TKD guideline from KDIGO mentions that creatinine cystatin C based GFRs are more accurate. One must remember that in cirrhosis, however, studies have shown that even that underestimates care. Now let's look at some specific AKIs that happen in the setting of cirrhosis. HRS AKI is obviously the top of the list and the one that has the worst prognosis, and some others that we just discussed. We will briefly look at them and then move on to the management of AKI. HRS AKI as such occurs in about 15 to 25% of hospitalized cirrhotic patients, and 10 to 30% of these actually have HRS, and the rest of them have other causes of AKI, which can range from acute tubular injury to interstitial nephritis and so on. Uh, in the prevalence of HRS in the setting of SVT and infections is far more as compared to other less common ones like in alcoholic hepatitis or serial LVP. Now, these are prevalences based on individual studies and may vary to some extent. Now, who are the patients in whom you would consider these diagnoses? These have to be cirrhotic patients. It could be an acute and chronic liver failure, but it has to be cirrhosis. And the patients could also have a permanent hepatic failure, in which setting the renal impairment could be attributed to HRS if it satisfies the criteria. In other rarer situations could be a metastatic tumor and alcoholic hepatitis. Alcoholic hepatitis per se is not rare, but in alcoholic hepatitis, even if frank cirrhosis or CLD is not present, they could develop HRS AKI. So, a brief on its pathophysiology has been shown here. This is somewhat complex, but essentially, what happens is that the liver is scarred, which results in portal hypertension because of all the scar tissue around the portal vessels. And in response to that, there is kind of a compensatory splanchnic arterial vasodilation to reduce the pressures overall. So, as an off target effect, what happens is the blood supply to the kidneys is reduced, and so the vasoconstrictors, that is the renin angiotensin system and the sympathetic system, gets activated. ADH also comes into play, and all of these cause retention of sodium and water, causing ascites and hyponatremia. What additionally happens in cirrhosis is something that is called as cirrhotic cardiomyopathy, where the cardiac function is affected because of the inflammatory milieu that occurs in the setting of cirrhosis. And a good contribution or a large contribution comes from the bacterial translocation that happens because of gut edema and the release of the PAMPs and the DAMPs. So, all of these together essentially cause a reduced renal blood flow, and it could either manifest only as ascites and hyponatremia without any structural damage, or there could be just a functional change where it is an HRS. If it is present for a longer time, the injury may become structural and an acute tubular injury may manifest, and there could be a combination of both the things happening simultaneously. When the another factor peculiar to cirrhosis is the presence of bilirubin. So the bile acids and casks, they themselves are oxidants, and they also cause kidney injury by tubular toxicity. But typically, the bile cast nephropathy would happen when the bilirubin levels would exceed at least 15 and in some cases to 20. So let's. The other thing of note that has changed in the past 1 year in the diagnosis of AKI is the duration over which you need to reassess the patient and consider for a diagnosis of AKI. So upfront, when a patient comes with AKI, the thing that is to be done is to rule out the treatable causes or the alternative causes. And usually, the top of the list is a pre-renal AKI, especially when it's the early stages of AKI. So the earlier definitions required for the clinicians to wait for 48 hours to label something an HRS AKI and give them HRS specific therapies. But now it has been updated to 24 hours. So as early as within 24 hours, if the volume resuscitation has been done and the patient continues to have renal dysfunction, a diagnosis of HRS can be made. So we have seen these are some of the things that can happen additionally. So whenever we are encountered with acute kidney injury in cirrhosis settings, some other factors to consider are bile cast nephropathy. These things have implications post liver transplant. Bile cast nephropathy, once the liver function resumes, it is almost completely reversible, except when it causes severe hemorrhage. A word about IgA nephropathy. Why it happens in the setting of cirrhosis is that the hepatic processing of IgA is affected because liver is not functioning. There is also portal systemic shunting, because of which the IgA will deviate from the liver and will get depolymerized, and this can get deposited in the kidneys, incite a reaction in the form of kind of antibody complexes, and also invite complements, which can cause an IgA nephropathy that may not appear different, or that won't appear different from the IgA nephropathy in primary GNs. Now, what happens to this after liver transplant is that more often than not, it can reverse, although a bit slowly. Only in certain cases, when the damage has been severe and glomerulosclerosis has set in, a complete reversal of kidney injury because of IgA may not happen. Hepatitis B and C, we are seeing them be less commonly these days with the advent of antivirals and a good management of these hepatitis. Primary injury to the kidney has become less common. Renal venous congestion also is something that is more hemodynamic and is reversible. Now, what happens because of what are the implications of renal dysfunction in cirrhosis? One is that, of course, it increases mortality. But the other thing is that the way severity of cirrhosis is defined is by using a score which is called MELD, which consists of parameters like bilirubin, INR, serum creatinine. So this makes it obvious that the presence of serum creatinine, anybody with a higher creatinine would have a higher MELD score. So MELD is a score that is used to decide on eligibility of a particular patient for liver transplant. So because of the addition of creatinine in this, it is an extremely renal function has a huge implication on the eligibility for transplant as well, irrespective of whether you are additionally considering an SLTT or not. The renal function is clearly important for drug dosing in all settings, and so it is in this case as well. So we'll talk a little bit about SLKT towards the end of my talk. We'll come back to this. So in patients who have suffered an AKI in cirrhosis, the implications of this continue to remain after they receive liver transplant as well. So anybody who has received a renal replacement therapy for less than 10 days would do better than anybody who has received it more. So this dichotomy does exist. In patients who do not have that severe an AKI. In fact, in this particular study published in 2015 in liver transplantation, the baseline creatinine is not too high. It actually would not even be qualified as an HRS by the older definitions. If there was a presence of HRS, there is clearly a separation of the renal outcomes. That is, the creatinine continued to remain high, not just in the initial 2 weeks, but also up to 1 year. This M12 refers to the month 12. So up to 1 year, the patients can have risen creatinine if they've suffered an AKI prior to liver transplant. This was a data in patients who have received disease donor liver transplant. So a huge data published in AJT from Korea, which dealt with the living donor liver transplants. They have also shown that if the patient had a diagnosis of HRS as a cause of their AKI prior to liver transplant, their overall survival as well as non-recovery is much higher than the patients whose diagnosis of AKI who did not have HRS prior to liver transplant. These are some statistics to just give you an impression that HRS actually tends to resolve in most of the cases. As is obvious, the basic pathophysiology here is the presence of liver cirrhosis. So in the presence of a good functioning liver, HRS should ideally resolve by rule, but that happens only in about 75 to 80% of cases. And it does so within the first 2 weeks. And if it doesn't, then it can have long-term implications. How that affects kidney allocation, we will be coming to that shortly. The cumulative incidence of non-recovery in patients who suffered an HRS is about 10% in some other study. Now let's look at a quick case, which is an everyday case for patients in hepatology or the hepatopnephrology clinics. This is a 55-year-old male who had a history of an alcohol use for over 30 years, and then he suddenly was brought to emergency with a GI bleed. That is when he was diagnosed with a chronic liver disease. He was otherwise doing fine until recently when he came with worsening abdominal distension, reduced urine output, confusion, and jaundice. On examination, he had flaps, he had low blood pressure, and tachycardia. His basic investigation revealed some anemia, thrombocytopenia, possibly some infection, a rise in his bilirubin levels, LFTs were deranged, and the creatinine had risen to a level of 2.4. And his ascitic fluid had an absolute neutrophil count of 323. So it was a high low protein, and it was a high low protein ascites. Cultures were sent. The ultrasound showed normal sized kidneys. So what do we do in cases like these? So typically we'll be doing all these routine investigations, but in addition, the ones of critical importance are to look at the urine microscopy, look at the proteinuria, and the stool or gallbladder. These are essential, along with ruling out structural causes by ultrasound, are essential to consider the diagnosis of AKI, of HRS in the setting of AKI. Some other things that may be used is the fractional excretion of sodium and biomarkers, but these are not very well established. So before we even consider HRS and jump on to starting early present in these cases, what is most important is volume resuscitation. So POCUS can be of great help in all of these cases. So anytime AKI is diagnosed, especially when it is early, volume resuscitation is the first thing that needs to be done. This is just to show that how bile casts may appear in urine. So urinary examination is invaluable and should be done in all cases. The presence of bile casts are somewhat difficult to find and may sometimes require special stains and may not appear upfront in the routine examinations. So coming back to POCUS, so one other thing to remember is that not all hypotension is hypovolemia. Hypotension could be originating from cardiac causes, and in addition, it is important to know that a patient who is hypovolemic may not always be volume tolerant. So, a continuous assessment is essential, and a comprehensive assessment. So, POCUS does not just include the IVC that we typically associate volume with, but in addition, other factors like cardiac contractility, a simple bedside echo, just looking at cardiac contractility will give some idea. So there are certain pitfalls that one must remember in cirrhotics, especially. What happens is IVC can sometimes be confused with an aorta. It can be difficult in mechanically ventilated patients to see, and the alterations in liver architecture can also affect the way you see IVC. And tensicitis can also make it difficult. Lung ultrasound can give you some clue about the presence of fluid overload if it is present, if B lines are present. So this is how AKI is diagnosed, but the biomarkers can be of some help here if we want to distinguish between HRS AKI versus the other causes of AKI, that is the ones that occur because of tubular injury or GNs or some other causes. In certain cases, it might be truly difficult because in cases of MASLD, that is the metabolic syndrome associated liver disease, a patient may have a baseline proteinuria, and such patients may still have an HRS, and the baseline proteinuria may make it appear like it's possibly an ATN because the urine is not clean, it is showing some structural damage. So, some biomarkers that have been tried in cirrhosis and have shown good value are NGAL and some other microRNAs, but these are not widely available. Hopefully, we'll have better biomarkers to distinguish HRS from non-HRS so that we can start treatment for HRS early. Now, once the AKI is diagnosed, the next step is to know the causes. As we discussed earlier, we'll first be looking at prerenal azotemia. We'll look for the presence of shock, nephrotoxins as is required in the definition of HRS. Before labeling it HRS, all these will be ruled out. The fractional excretion of sodium is a useful entity. Even if the patients are on diuretics, it does give some idea. Some people have used fractional excretion of urea instead of sodium as the use of diuretics may affect sodium excretion. The urine NGAL has been shown in a couple of studies to be a good, reliable marker of HRS. If it is present, so NGAL is something that will be released from the renal tubules. If it is present in the urine, it's more indicative of a tubular damage. And if not, then possibly this is more functional, and in which case it is called HRS. So this is a suggested algorithm that can be followed bedside for patients who have AKI. Once the AKI is diagnosed by the set criteria, all the essential things have been ruled out, which are the alternative causes. urinary biomarkers can be done. Fractional excretion of sodium is relatively easier to get. NGAL is, it may be difficult in resource limited settings, but if it is more than about 200 microgram per gram of creatinine, it might be more suggestive of an ATN. So, coming to the treatment options that exist for HRS, volume resuscitation is the first pillar that needs to be addressed, and within 24 hours, we must consider a vasoconstrictor therapy. Renal replacement therapy is for standard indications. There are no liver-specific indications of renal replacement therapy except when the bilirubin is very very high, refractory hyperbilirubinemia, and very high ammonia. Although these are also debated. The other therapies are TIPS, that is transjugular intrahepatic portosystemic shunt, the use of an extracorporeal liver support system, and finally liver transplant. So, briefly about volume resuscitation, the offending agents have to be stopped. Laxatives, diuretics need to be stopped right away. The kind of fluid you would choose would preferably be a balanced salt solution, although this is also debated and there is very less data in liver cirrhosis patients per se, and the evidence is actually derived from other critical care settings. Albumin may be particularly of benefit in volume expansion. We'd rather call it volume resuscitation than expansion because expansion may not be tolerated very well by these patients. We can use POCUS to some extent to guide as to what should be the end point of giving a volume, and it can also guide as to when to stop and not to proceed further. Serial measurements may be more useful than one-time measurement. Albumin is definitely something that causes short-term improvement. We clinically also see that, but one must be wary of pulmonary edema. Excessive albumin or increasing it to more than 3 grams per dl has no substantial benefit and can put the patient at risk of pulmonary edema. So, another word about the presence of pre-existing CKD, something that is yet to be addressed separately. That how much, what should be the baseline proteinuria, and an increase of what amount of proteinuria should be considered more consistent with AKI rather than HRS is not clear as of now. So, the important thing to remember here is that the volume resuscitation has to be done within 24 hours, and then we have to consider the diagnosis of HRS. In which case, the specific therapy as of now is giving an albumin with a vasoconstrictor. The vasoconstrictor that is approved for use in this setting is terlipressin. It increases the mean arterial pressure and the kidney perfusion and causes flattening arterial vasoconstriction. Albumin will additionally give narcotic benefits and will retain the fluid in the intravascular space. Terlipressin has got two regimes, bolus and continuous. Many times when these patients are seen on an outdoor basis and cannot be admitted in resource limited settings, it is difficult to admit all of these patients. They are sometimes given bolus regimes. One must remember that if we go by evidence, continuous infusion is as effective as bolus, but the adverse effects can occur more with bolus doses rather than continuous infusions. So, in summary, terlipressin is something that has the highest evidence and the best of benefits in terms of reversal of HRS AKI. And if terlipressin is either not available or can't be afforded, then the other lines of management are giving noradrenaline and midodrine and octreotide. So, if there is no improvement in MAP and the diagnosis of HRS is more likely, then in that case you need to review again as to what are the other causes and whether there is a component of cardiac decompensation as well. So, with all of these therapies for HRS AKI, what happens is if the patient has a lower baseline creatinine, lower bilirubin, and then has an increase in MAP with the therapy within the next 24 to 48 hours, has a lower grade of acute and chronic liver failure with lower NGAL values, they tend to respond better. In our case, the patient had a partial response to terlipressin and a partial, for the mistake there, and a partial reversal of AKI. And he is now on a liver transplant wait list. So the creatinine at the time of starting terlipressin is very important because studies have shown that if the creatinine is essentially more than 5, there is the chances of reversal of HRS are very, very low. The sooner you get them, the sooner the diagnosis is made, the better the chances of terlipressin acting and reversal of AKI. As said earlier, renal replacement therapy has no specific role in the management of AKI beyond the management of renal failure and the complications that arise from renal failure. However, the requirement of RRT does put in bad prognosis post liver transplant as well. TIPS is something that has been shown to be of quite some benefit, but the RCTs are lacking in this regard. There is an ongoing liver hero trial which shall hopefully clarify whether it can be compared very well to the standard of care currently, which is terlipressin with albumin. Extracorporeal liver support systems are not recommended as per present guidelines as a therapy for cirrhosis per se, but it is only a bridge to liver transplantation. If someone is on a liver transplant waitlist and have a likelihood of getting a liver transplant, then it may be considered. So post AKI, there is a risk of recurrent AKI. There is also a risk of progression to CKD. So these patients need to be on a periodic follow-up indefinitely. Now, coming to liver transplant, it is the best modality. It's the only definitive therapy. Unlike in kidney transplants, where fitter patients, patients who actually are doing very well, are taken up for kidney transplant, the opposite happens in liver transplant. The more severe the disease, the higher their MELD, they get a priority in liver transplant allocation. So if they have had a response to terlipressin and albumin prior to their liver transplant, they tend to have better outcomes. Now, lastly, we'll come to the consideration for SLKT versus LT alone. So, for the nephrologist, this is of critical importance because patients are referred to us as to whether they will likely have the reversal of their renal injury and should a kidney transplant be considered along with it or not. If they've had an AKI and they have received terlipressin, if they were responders, they would do better than non-responders. So this gives some guidance, but clearly more is needed. So an algorithm that can be followed is here. Anybody with a decompensated liver cirrhosis and is presenting with an AKI, we have to rule out all the alternative causes of AKI. If they're not present, then the diagnosis is consistent with HRS AKI. In that case, terlipressin treatment can be started. Either they can have good response to terlipressin itself, which is in significant proportion of cases. If it is an early AKI, the greater the stage, the worse is the response. If there is if their MEL scores are additionally higher, then the consideration for liver transplant or liver and kidney transplant is to be done. The criteria for SLKT is when the patient has an established CKD, that is a GFR of less than 60 for more than 90 days, and the lowest one, the lowest creatinine is 35 at the time of listing. And if the patient has had a sustained AKI, so in this context, what is meant by sustained is a dialysis requirement for 6 continuous weeks and having a GFR of less than 25 every 7 days. In addition, there is something called as a safety net in the liver kidney allocation. We'll come to that in the next few slides. So this is just to give you, this one is to give you a brief overview of how the kidney and liver allocation has evolved over time. Initially, patients with biopsy evidence of irreversible damage of more than 6 weeks were considered for kidney transplant along with liver. But the cutoffs for GFR were not very well established until 2009 when in CKD as well, the GFR of less than 20 or presence of proteinuria is considered as a criteria for giving a kidney transplant as well, along with liver. Sustained AKI definitions have pretty much remained the same over time. Now, we saw this a little earlier as well, that CKD and AKI sustained AKI, not just AKI, but a sustained AKI will be considered for a liver and kidney transplant. In addition, some rarer indications for SLKT would be a presence of metabolic diseases like primary hyperoxaluria, atypical HUS, and some other rare genetic conditions. So, coming to the second part of this. Now, if these all criteria, just going back to the GFRs for CKD. So at the time of listing, the GFR has to be less than 30. Why this is done is that there is a proportion of patients who have had an AKI and they can have recovery post-transplantation. So in these patients, giving them kidney and liver alone will sort of cause inequity because these kidneys are drawn from the pool of patients who require kidney alone. So in the updated 2017 OPT and safety net policy, what they have done is that in patients whom kidney transplant was not done and only a liver transplant is done, and within the next 1 year, if they if they continue to be on dialysis or if their GFR continues to be less than 20, then they are given a priority for a kidney after liver transplant. The advantage of the safety net policy is that, and there are a couple of papers that have been published as to the impact of the safety net policy, is that the number of kidneys that are drawn from the pool of available kidneys for kidney transplant alone patients have somewhat increased because more patients are now being offered liver alone because they have a safety net policy, and should there be a requirement of kidney transplant, it can be done at a later date within year. Now, just the last few slides in this regard, one must remember that all of these definitions and criteria are based on assessing renal function, but that's not very good in cirrhosis. Using the routine methods like creatinine and creatinine-based equations, even the CKD-EPI equations, are far from accurate. There are plenty of reasons for this. Lower muscle mass, volume of distribution, as we saw earlier. In addition, there is a variation that happens by ethnicity. So there is no great validated formula for knowing the GFR in cirrhotics. Kedigo asks us to use the statin C, but as we saw, even that is somewhat less accurate. The gold standard methods are plasma or urine clearance methods, plasma more so than urine methods of some kind of a endogenous or exogenous marker. So whatever is measured, that is the marker that is given intravenously and taken at timed, and blood samples taken at timed intervals to know its concentration, is called as a measured GFR as against the estimated GFR that you get from various formulae. To note here is that even urinary creatinine clearance is not very great in cirrhosis and not quite accurate. There are some practical solutions like some equations which have been developed for cirrhotic patients, namely the Royal Free Hospital GFR and the Grail GFR. This is how they look online. You can access them from your laptops or phones. But what is needed is that you need validation studies. These GFR formula, which are specific for cirrhosis, also have not performed well in all kinds of patients. The presence of ascites also makes one particular formula better than the other. That is, for example, the Grail. Now, I will end with what we found in our study, which is an ICMR sponsored study conducted at PGI. This is how the GFRs vary. The formula-based estimated GFRs are extremely inaccurate when you consider the blue one. The first one is the gold standard GFR. So the other GFRs are far higher than this GFR. You can use either DTPA or plasma iohexol method. These are all for research purposes and cannot be used in everyday life. So there is a huge need for assessing renal function accurately in these patients that still remains. So this is an ongoing work at our center, and the report from the initial few patients were published in the JCEA journal, where we found that in Indian patients, the RFH formula actually worked as good as statin C, with an accuracy of close to 80%. So I'll conclude with this take-home message. AKI and cirrhosis has a grave prognosis, and the mortality increases up to 1 year or even more. Upfront use of vasopressors should be considered if the volume is repeat and decide on this within 24 hours. Vasopressor trial may be futile if the creatinine is too high at this condition. All of these therapies are actually a bridge to transplant, and liver transplant is the only definitive treatment. We do need better biomarkers to predict the recovery of renal function post liver transplant. Thank you.
Thank you, Dr. Smita, for an exhaustive lecture on this particular clinically challenging situation. But since
I cannot hear. Yes, I can hear you now.
So thank you once again for giving us an exhaustive review of this particularly clinically demanding situation. Since we had already started running late, we won't take any questions or comments from the floor. We'll move to the next session, please. Thank you.
One
Thank
line,
you.
Smita. One line, just one line. Thank you for joining us and giving this lecture. One important thing I want to highlight for students sitting in the back rows, that they should note this GFR related issue, MGFR versus EGFR, and how we could reach a more close EGFR to MGFR is the issue. And you know that in a resource limited setting, it's not very easy to do an iohexol or inulin based GFR. So the way you are proceeding, comparing the Indian standard, I would keep an eye on it, and we'll ask our students also to follow your publications, and that would be extremely helpful in Indian situation, as it would address the Indian population. And number two is, I am repeatedly finding now the liver transplant is happening in Kolkata as well as other places where people get LD, LT done. They are being referred to us, and who are the Kolkata residents, and we nephrologists are often looking at the worsening creatinine and gradually moving up to the, I think when our students will be corroborating with the liver department, they will also need to see, and our faculties need to be part of the allocation system decision, that whether SLKT or LDKT, liver transplant followed by kidney transplant, what would happen actually. That's why I kept your session and a little later the crosstalk session. So I would be happy if you be available in the crosstalk session as well. You may join as a participant. Please have a look at the timing if you can make time. Thank you.
Thank you so much. Thank you. Always a pleasure to see you.
I think Shogatu will be asking you something.
Thank you, Ruby, for this nice presentation. So I have a query that in critical, are you listening?
Yes, I can hear you. Only it will be a little louder.
Louder. Yes. Actually, when patients are critically ill, most of the time we resort to noradrenaline rather than terlipressin because we want to elevate the MAP. Earlier concepts was like elevating MAP gives the equal benefit of raising creatinine decline as terlipressin. Like US was not supporting terlipressin, their long time was advocating noradrenaline. And in ICU also you get to see that when RRTs are required, blood pressure further drops in this sort of patients. What is your take home that how do you manage such critically ill patients when we take for renal replacement therapy? And another thing is that what do you choose, online HDF versus traditional hemodialysis? Many such patients do not tolerate hemodialysis, and some studies do show that online HDF must be better. And as you show that bilirubin lowering therapy is not critically important, but when bile casts are concerned that whether such bilirubin absorption columns are useful when we deal with such patients. Thank you.
Yeah. Thank you, Dr. Shogato. So it is true that these things are very difficult to manage. But what I want to highlight is that see, once the creatinine is very high and the patient is in a dialysis requiring state, there is no role of terlipressin as such in the reversal. In these cases, the response is going to be extremely poor. We have actually already sort of missed the bus, one would say. Now, the early AKIs, when the creatinine is only mildly deranged, that is when the volume resuscitation and terlipressin comes in. Once these patients are dialysis requiring, we try to make a judgment whether this is an ATN, and if we treat the underlying cause, more often than not, it is sepsis of some kind, either SVP or a chest infection. And if that is addressed, then these patients may likely improve with their renal function as well. If it is HRS alone with the creatinine that bad, then the chances of recovery are minuscule. So occasionally we also counsel them about palliative care. If it is likely to be futile, then RRT is not going to, unless a liver transplant is forthcoming in the next week or so, there is no point of doing it. As far as the RRT modality is concerned, CRRT is offered in our institute, but it is not practically possible for everyone. So affordability issues do remain. We have good experience with just giving saline flushes, even with CRRT. Only occasionally we have used regional citrate anticoagulation to keep the circuit patent. So, and if you go by the guidelines, if they have hepatic encephalopathy present, then it is recommended that you use a continuous replacement therapy rather than an intermittent one, which causes too many fluid and electrolyte shifts. So CRRT is preferable, but if they're not in shock, then you might, if it's possible, then SLED may be given. Now, indications of dialysis only for bilirubin removal, we have rarely done that, and we've usually done that only if it is a fulminant hepatic failure or a refractory cholestasis. The diagnosis of wild cast nephropathy cannot be made unless you did a kidney biopsy. And the presence of very high bilirubin alone is not an indication for dialysis as such. There is some data to say that very high bilirubin may be neurotoxic on their own, but typically these patients additionally have other indications, so more often than not, they end up receiving dialysis. And in that case, we would, if we had all the resources, then we would prefer CRRT. Otherwise, prolonged sessions of SLED might do just as well.
So thank you, Smita. We will proceed for the next session.
Thank you so much. Thank you.
Please try to join the crosstalk session if possible.
I will try that. Thank you.
Thank you.
Thank you.
Nice to see you. Every time I see you, I feel good. So next talk will be from Dr. Neetpi Anier, who will be speaking on pre-transplant genetic counseling again. We wanted both sides of the coin to be revealed, both sides of the coin to be seen, and Dr. Dipanjana Datto, who is a geneticist from Kolkata, will be chairing the session. Dipanjana, you should come here or here now. No, you come here. No chairperson in back row. She is a geneticist and helping us out in deciphering the complex genetic reports. I wanted Rajiv also to be here, but Rajiv is not.
Please put it first. Okay.
So, Shukra I'm Nick here. I'm a kidney doctor and I run the Inherited Kidney Diseases Clinic at St George's Hospital in London. So we've gone from here to Lucknow to Chandigarh and now to London. And when we hear from Victor, we'll be hearing from Mexico. So we're getting steadily further away from where we are. Should we just go to the next slide? Oh, yeah, so that's my statement of interest, but superimposed on a picture of the original St George's Hospital from 1733 back in London in Hyde Park Corner, which you must come and see when you visit. Next slide. Oh, right, so I thought I'd start with a case story, because of course there's always a risk of overlap when given the same title of talk as Professor Prasad. So I thought I'd just start with what I know that he won't have seen, which is our patient from St George's. And this was a 31-year-old Caucasian British man with end-stage kidney disease. He presented in end-stage kidney disease secondary. We subsequently found chronic tubular interstitial nephritis on his kidney biopsy. So he presented with a creatinine, a serum creatinine of 720 micromoles per litre. I forget what that is in milligrams per deciliter, but it's end-stage kidney disease, dialysis requiring. And previously, so this was March 2022. In 2009, he had a creatinine of 103 micromoles per litre, which is already impaired. But it's shown that over the course of 13 years, things have progressed quite significantly. And he'd been on peritoneal dialysis when I saw him in the inherited kidney disease clinic since July of that year, and he was currently on inpatient antibiotics for PD peritonitis and looking pretty miserable. And he was on a number of medications to support his end-stage kidney disease, including 1-alpha-galstol and quinine sulfate for his cramps. He works as an environmental technician. He's intellectually relatively normal, but still living, aged 31, with his mother, father, and grandmother, so a pretty busy house. And he did have a history of cocaine use once a week at weekends for some years. So next slide, please. Is that the next slide? Well, yes, possibly it was. Yeah, so next slide, brilliant. So no, next one. Perfect. So this is his family pedigree. So this is his mother and father with whom he still lives, and his surviving grandmother. There is a maternal uncle with end-stage kidney disease in his 60s, reportedly likely due to reflux nephropathy, and he had a kidney transplant around 10 years or so ago, so aged in his 50s, and he was starting to suffer some problems with his memory. Oh, fantastic, thank you. And this is him, 31, and he's got a 26-year-old sister who's currently pregnant. And his father has come forward, age 50, as a potential kidney donor. His urine is pretty clear, his urine dipsticks are normal, and he's got normal kidneys. In fact, his mother also has clear urine and normal kidney function, and could also be a potential donor. But next slide, please. This is a CT scan of his abdomen, and we just picked up that he seems to have some nephrocalcinosis. And next slide, please. And the histopathology on his kidney biopsy, it demonstrated a significant chronic damage with a significant tubular interstitial nephritis. There is some suggestion of a superimposed acute tubular necrosis, and the findings would be in keeping with a chronic tubular interstitial process from cocaine use or an inherited condition. And next slide, please. And so we sent off a genetic panel looking at for all at that time known genetic associations with end-stage kidney disease of a young onset, and it demonstrated a pathogenic mutation in CLCN5. Next slide, please. So what is CLCN5? So CLCN5, this is dent disease. A chloride voltage gated channel, number 5. It's an excellent recessive condition. In dent disease, we have CLCN5 and also OCRL1 pathogenic mutations. It's a renal tubular disorder, characterized by proximal tubular dysfunction, low molecular proteinuria, hypercalciuria, nephrolithiasis, nephrocalcinosis, and progressive chronic kidney disease. It's generally speaking males that are affected, with progression to end-stage kidney disease between their 3rd and 5th decades. He's 31. He's relatively young, but this is in 30 to 80%. And whilst female carriers, who are generally obligate carriers, may show a milder phenotype, often they have no recognisable chronic kidney disease at all. Prevalence generally unknown, and in 2010 there were around 250 families affected, but I think this is another family. Next slide, please. And this is just a quick diagram to remind us of where the chloride channels are on the proximal tubular, proximal tubules of the kidney. Next slide, please. So in terms of treatment, there are complications such as rickets or osteomalacia. A few patients with dent disease don't harbour mutations in CLCN5 and OCRL1, so there may be involvement of other genes, and as we do more and more genetic testing, we're more likely to find these. Or it may be that there are just other epigenetic foci or other ways in which these genes may be involved that current sequencing technologies haven't yet identified. Currently, antenatal diagnosis and pre-implantation genetic testing is not advised. I suppose if we look back at his family tree, we'll kind of understand why. But the care of patients with dent disease is supportive, focusing on the treatment of the hypercalciuria and prevention of nephrolithiasis. Next slide, please. So we go back to his family history. We can see that this is an X-linked recessive condition. His mum is, in theory, an obligate carrier. We don't know about his 2 aunties with Down syndrome, but that would help explain the cause of end-stage kidney disease in his maternal uncle. And it would, in theory, preclude his mother from donating, as there's a certain risk of progressive chronic kidney disease in her. And then what about his poor sister, who is currently pregnant with what turned out to be a son? But it does reveal that his father is a good potential donor. Next slide, please. I think I've probably just summarised that already. So it established the implications of this genetic diagnosis for our patient. It established the cause of his renal disease. He was feeling so guilty that he was addicted to cocaine on weekends. And we found that it wasn't his fault at all. His transplantation would be an effective treatment because it's not going to recur in his kidney. It enabled genetic counselling for his mother, and once his sister had given birth, then we started talking to her. But that was quite a few phone calls, and it determined that his sister may not be able to donate as she'd otherwise want to once she gave birth. But it did confirm the father as a potential donor. So renal genetics is enormously powerful in this case and in so many other cases. And we should go to the next slide. So genetic kidney diseases are common. They affect 10 to 15 cases of adult end-stage kidney disease and most children on dialysis with end-stage kidney disease. There are over 600 genes associated with monogenic kidney disease, and the independent predictors of monogenic disorder, and we've heard this from Professor Prasad already, a positive family history, early onset, less than 25 years old, cystic kidney disease phenotype, you know, the kind of cysts that you can see on the ultrasound on the CT from a mile away, they are more likely to be a monogenic disorder. To the point where sometimes we haven't been doing genetic testing at all. But from the previous case, you can see how effective, how useful it can be to do genetic testing in such cases. The presence of extrarenal manifestations which suggest another underlying genetic condition which is affecting not just the kidneys but all other organs in the body. And all of these coming together should prompt genetic testing. Next slide, please. This is a summary of, I suppose, how to improve the whole of genetic testing in our chronic kidney disease patients. If you take a sample of patients with kidney transplant or end-stage kidney disease of any cause, you can enrich the likelihood of getting a positive genetic diagnosis from between, next slide please, between 9 to 50% amongst your patients with end-stage kidney disease. Okay, next slide please. So genetic testing techniques have come on an enormous long way, and Professor Prasad gave us a beautiful summary of how it started with the Human Genome Project back in 2000. And back then, our normal standard method of testing would be through single gene sequencing or targeted genetic panels. You identify a good phenotype, a cystic kidney disease phenotype, and you would pin down the likelihood this was PKD1 or PKD2. And this is really effective in well-defined clinical cases where there is a very strong suspicion of a specific monogenic disease. For example, Fabry's disease, TSC, which is a genetic condition which I'll talk more about tomorrow. Yes, definitely tomorrow. Primary hyperoxaluria, C3 glomerulonephropathy, etc., etc., etc. And also in familial cases where there are specific phenotypic patterns like cystic kidney diseases, tubulopathies, and steroid-resistant nephrotic syndrome. But whole exome sequencing, whole genome sequencing, and virtual whole exome sequencing using kind of multi-disease kidney panels are becoming more effective when multiple genes are potentially involved. And they're really effective at exploring all coding regimes of the genome in an unbiased manner. And detecting additional genetic diagnoses that aren't captured by conventional genetic testing. They allow for future reanalysis if there's new pathogenic genes are discovered, and far more efficient in high genetic and phenotypic heterogeneity of monogenic diseases. And so very effective in, for example, our case with a young onset end-stage kidney disease, what on earth is happening? Although if we think about it, if we put the nephrocalcinosis together, or we put the young onset end-stage kidney disease, we'd have got there. But by applying an unbiased panel, we also got there. And as, next slide please, the cost of whole exome sequencing, whole genome sequencing is coming down from 2000, where we got there several $1 million, we've come down to portions of $1,000 per whole exome. And this is just coming down. And this is, makes, next slide please, it much, much more widely accessible and therefore ever more transferable and translatable to kidney transplantation, which is why we're here. So the applications, I suppose to a degree I'm repeating what Professor Prasad says, but it's most effective by repeating what Professor Prasad says because it means that we have an agreed approach to what we're doing. We can influence recipient diagnosis and management. We can identify the cause of kidney failure. We can help predict the risk of kidney disease recurrence after transplantation or not. We can inform the need for preemptive therapies before transplantation, before end-stage kidney disease, and after transplantation. We can help manage extrarenal manifestations of genetic disease, for example, with hearing, vision impairment in Alport syndrome, with cerebral vascular abnormalities in PKD, with hepatic sequelae in PKD, with TSC, with brain and renal and ocular and cardiac manifestations, and in VHL with extrarenal malignancies too. In donor risk assessment, we can identify potential kidney donors, particularly living-related kidney donors amongst the family who would otherwise be identified as being at risk for developing kidney disease or other conditions. And we can help make informed decisions about donation and protect donor safety. And the example that we kind of brushed over a little bit because it's less relevant in Indian populations to our knowledge at the moment is APOL1 gene testing. Now, genetic studies have shown the significance of APOL1, particularly in high-risk genotypes found in individuals of African ancestry, which can influence both donor risk and graft outcomes. And we'll talk about that in a little bit more detail in a second with the help of some of my colleagues who are in London. And then the prospect of personalised medicine, as Professor Prasad indicated, by understanding recipient and donor genetics, transplant decisions can be more personalised, not only through the HLA typing, but also through pharmacogenetics, through thinking about CYP3A5 and gene mutations, how that influences transplant immunosuppression, and also with gentamicin and mitochondrial genotypes as well, and how that gentamicin is so very widely used in kidney medicine, and the potential for causing deafness in that setting too. Next slide, please. So in the UK, we have the relatively newly implemented National Genomic Testing Directory, and this offers currently 13 different indications for genomic testing in kidney disease. These are the 13 indications, and you'll recognise them as common kidney phenotypes, including cystic renal disease, hematuria, proteinuria renal disease, CFHR5 nephropathy, membranoproliferative glomerulonephritis, renal tubulopathies, congenital abnormalities of the kidney and urinary tract, or CAPUT, where these are familial, atypical HUS, tubulointerstitial kidney disease, hereditary systemic amyloidosis, nephrocalcinosis or nephrolithiasis, unexplained young onset end-stage kidney disease, probably my favourite panel to be honest, and most recently APOL1 kidney donor testing. So these 13 indications, and there are more, are all available free of charge to our kidney unit, but charged to the national genomic testing centres, allows us to do theoretical access to genetic testing for all of our kidney patients wherever they live across the UK. But of course, as you can imagine, the widespread genetic testing is mostly happening in the transplant centres, and less so in the peripheries out on the coast and in the smaller district general hospitals. So one of my many tasks is to help improve understanding of genetic testing and how to access it for our communities, our renal community out in the periphery of the UK. The whole genome sequencing indications are just 3: the cystic renal disease, proteinuria disease, and unexplained young onset end-stage kidney disease, where we have a lot of potential candidates. And only over the last 10 years, we have seen something like the swelling of cystic kidney disease go from just PKD1, PKD2 to the advent of several more novel, different cystic kidney genes, such as DNAJB11, IFT140, all of these other kidney. These have been reported through unbiased genetic testing of patients with cystic kidney disease, and it's a fascinating field. Anyway, I should move on. Next slide, please. So genetic testing in kidney patients, I suppose broadly we're looking at is this disease genetic? And sometimes we just don't know. Sometimes we have a patient with no family history whatsoever, but the phenotype is suggestive, or we just have that clinician's gut feeling, or we have a patient's gut feeling that they would like genetic testing as well, which it offers a different influence in the kidney, in the clinic. Which test to use? We've already demonstrated that on using the simplified 13 indication National Genomic Testing Directory. And we talk to the patient, we talk about the risks of coming up with a definite diagnosis, because we're absolutely confident that this phenotype that they presented with is absolutely definitely a genetic condition. But at the same time, we also warn them of the risk of getting no diagnosis whatsoever, or of getting a variant of unknown significance, which is entirely unhelpful to them and won't allow us to talk more about the disease at the moment. But maybe more information will come after someone's done a PhD for 3 years, or maybe even after that. So there is a risk of a clinical question, just hanging in the air for a long time, long after they've reached end-stage kidney disease, which is also an impact on them. And then we send the request, and that request can take 9 to 12 months to come back, mostly because of the laboriousness of the actual test, of the actual analysis. Next slide, please. So this is just a little bit about the APOL1 story, which I find genetically fascinating, but I recognise that it has less relevance in India at the moment. So APOL1 encodes an apolipoprotein, L1. It's evolutionary new, just present in humans and some primates. There are 2 African ancestry-related APOL1 gain-of-function haplotypes called G1 and G2, which confer innate immunity to African trypanosomiasis. And so here we have a kind of environment and genetically influenced evolution of these G1 and G2 haplotypes, which then, whilst they confer improved immunity to trypanosomiasis, have also confirmed an enhanced likelihood of associated kidney disease. And this kidney disease can be of almost any phenotype, of proteinuria, just progressive chronic kidney disease, of HIV-associated nephropathy. So there is a 7 to 10-fold risk in the high-risk genotypes of G1 and G2, or G1G1 or G2G2 haplotype patients. 7 to 10-fold risk of non-diabetic hypertension associated end-stage kidney disease, 15 to 20-fold risk of FSGS, and a 29 to 89-fold risk of HIVAM. Next slide, please. And so these high-risk APOL1 genotypes in donor kidneys are associated in the recipients with faster allograft failure, and in the donors with more rapid decline of eGFR and an increased risk of end-stage kidney disease. The risk of the high-risk APOL1 genotype in recipients is slightly less clear. So currently, the indications for APOL1 genetic testing on the National Genomic Testing Directory in the UK are solely for testing for potential living kidney donors, where the individual being assessed for living kidney donation, the individual is being assessed for living kidney donation. Both of the individual's parents have African American, Caribbean or Brazilian heritage, and the individual has undergone counselling about the genetic testing. Next slide, please. And so we have implemented this model at St George's with our kidney transplant service, and our colleagues Janice and Richard have compiled a case series of 11 patients who we've tested so far. And next slide, please. Oh, next slide, please. Sorry, I could dwell on the detail, but the broad speaking, we've done a small number of patients of APOL1 testing, and around about 30% of them have high-risk genotypes. So 30% of potential donors worked up for end-stage kidney as potential donors for their relatives have been assessed as being high risk, and that has halted their transplantation, but it has allowed the other 70% of transplants to go ahead. Next slide, please. And oh dear, sorry, slide's a little bit untidy. But broadly speaking, we are managing to turn over the results for this relatively simple genetic test over 52 days. So it is not mutually exclusive to proceeding, it's not slowing down the course of transplant donor workup, where the standard wait of 9 to 12 months for other genetic testing indications really would delay proceeding with transplantation. So next slide, please. And I was going to talk a little bit more about pharmacogenomics, but I suppose broadly we recognise our colleagues, Professor McPhee, previously about 10 years ago, has done pharmacogenomic testing looking at CYP3A5 mutations, the prevalence of those amongst African patients, looking at the question of why some of our African transplant recipients are requiring considerably higher doses of tacrolimus than others. And it turns out that the CYP3A5 mutations can be associated with a requirement of much higher doses of immune suppression, which allows us to increase our baseline immune suppression for those patients. Let's move on. And similarly, genetic kidney diseases can prompt screening for extrarenal complications, and I thought I'd just kind of highlight the importance of extrarenal screening for extrarenal complications amongst PKD1, PKD2 patients, TSC patients, VHL patients, and steroid-resistant nephrotic syndrome. We mentioned WT1 variants a little bit earlier. Mitochondrial diseases may be associated with an increased risk of post-transplant diabetes, alongside those patients with cystinosis and HNF1 beta mutations as well. Next slide, please. And of course, genetic kidney disease may dictate a risk of recurrence post-transplant. So those patients with FSGS mutations in polycin, in atypical HUS with DPKA, KE and CD46 mutations in C3 glomerulopathy, and in primary hyperoxaluria, all enhanced risk of recurrence in transplantation without appropriate treatment. And that can help determine what we do post-transplantation. Next slide, please. So there are lots of pros and cons of genetic testing. In the American College of Medical Genetics definition, a positive test result is defined as detection of a pathogenic or likely pathogenic variant in a gene that matches the mode of inheritance and the phenotype. And the classification of these variants as pathogenic or likely pathogenic, though, is a dynamic process, and it changes with new discoveries. So one day you might have a variant of unknown significance, the next day you have identified a whole other family, or an extra member of the family with the same mutation, and you are ever more convinced that this variant of unknown significance is likely pathogenic. A negative test result, therefore, should not provide that reassurance that the Mendelian disease, kidney disease, has actually been excluded. So suffice it to say that we are trying to make sure that providing a correct diagnosis is more important than an incorrect diagnosis. An incorrect diagnosis can lead us down the garden path and make us give incorrect communication to our patients, which is dangerous. There's a high risk of certain variants of unknown significance reporting, which can cause, as we say, incorrect diagnosis, particularly in the absence of interdisciplinary contact between the clinician and our geneticist, which is why it's so important to have to improve training of all of us, so that we all understand kidney genetics and also then know when to call for help. And also to appreciate as well that the knowledge of the carrier status or non-carrier status for a genetic variant can have a negative psychological impact on the patient and family members. or for outpatient, our 31-year-old environmental technician, which was another way of saying he was working as a binman. But he was so guilty that he had caused his end-stage kidney disease, and that genetic test result completely just lifted, you should see him, lifted the weight off his shoulders. But it put an enormous weight on his sister, who was just about to give birth to a son. This is just to say that there are 5 different classes of variants, either benign, lightly benign, variants of unknown significance, lightly pathogenic, or pathogenic. And as you go more into the red zone, you're a bit more confident of what you're saying. Once you go into the yellow zone, you're just not sure, and you need to do more work. You need to seek for help. Next slide, please. And this is just to explain that it gets ever more complicated in our interpretation. And next slide, please. And so I thought I'd finish by coming to a different patient and just saying how it is dynamic. This is a 45-year-old Sri Lankan lady who had a clinical diagnosis of ADPKD. There's a positive paternal family history in her father and her brother. There's also a thalassemia trait, there's old TB, lymphadenitis, diagnosed in 1997. She's heterozygous for factor 12 deficiency. She works as a bank administrator, she hasn't been doing cocaine those weekends. And she's got multiple cysts in both kidneys, found over 10 years ago on ultrasound. There's no MRI scan yet to assess the total kidney volume, but we do know that her late father did progress to end-stage kidney disease and died for 3 years. He died of his 3rd stroke, age 60, having had a lengthy history of smoking and alcohol abuse complicated by liver disease. So whilst she didn't smoke cocaine, her father definitely did abuse other drugs, legal, and her older brother, 42, with ADPKD, has liver problems, is also a smoker, has 2 children aged 7 and 3, and also drinks a little bit of alcohol, as did his father. I don't think we have a genetic test for alcohol abuse as running in families. I think that's probably environmentally influenced, but we should move on. Next slide, please. So her ultrasound is fairly, it's clear. There are cortical cysts, multiple cysts in the cortex and on both sides. Next slide, please. And her kidney function is relatively stable, but there is a hint over the last 5 years of progression of her serum creatinine. Next slide, please. And here is that family history, where her late father, here, and her brother, oh, that's not a brother, it is her brother. No, sorry, this is the patient, that's the brother, with a wife and 2 children, and then a sister who's dug her head in the sand and hasn't wanted to be screened at all. And next slide, please. So we've got a fairly convincing family history of an autosomal dominant picture, and that initial genetic test result has come back in, when was it, mid-2022, and it's shown is negative. I talked to our genetic scientist and he said, I think there might be a variant of unknown significance in DNA JB11, but it's likely benign, so I'm not going to report it. So we went through the MDT and thought, oh, this is a very clear, beautiful autosomal dominant picture. We've got a very clear ultrasound, and I mean, we can't test the deceased father anymore. We could test the brother who's got the children, but the brother who's got the children is in between drinking and juggling the children, so he's not really interested in doing genetic testing, so we have her. And she is very driven. She is saying, I'm sure there's a result here. Anyway, there wasn't one. Next slide, please. So no established cause of disease. It doesn't exclude a genetic diagnosis. Doesn't enable genetic testing, screening for ADPKD in her relatives, in her brother, in her brother's children. It doesn't preclude tolvaptan treatment, if that's applicable, and you can see there is a hint of her kidney disease progressing. We can direct as a PKD charity, which is our local UK-based PKD charity, to help support the patient with her treatment and that likelihood that she will progress over time, as her father did, aged in his 50s. And we can recruit to RADAR, the Renal Rare Diseases Registry, which allows us to take all patients with rare kidney diseases and monitor their progress. Next slide, please. But we did, when we got the negative sample, the negative result, pass, because of the strength of this phenotype, we passed it down the diagnostic discovery pathway, which is essentially a genetic testing pathway which is outside of the front line of the people that have got the 1,000 results to analyse in front of them and have absolutely no time to look back at the old ones, trying to undertake PhDs with very convincing phenotypes, but no negative result. We passed it down there, and lo and behold, gosh, it was kind of middle of last year, so June 2024, so another 2 years down the line, we did identify a likely pathogenic mutation in PKD1. So next slide, please. This is pretty much the last slide. So we do now have an established genetic cause of disease. It allows us to, we were always able to use tolvaptan if we needed to, but it allows us to screen. It allows us access for PGTM, pre-implantation genetic testing for myelogenic disease, for her nieces and nephews when they come of age. Remember, there are only 7 of them at the moment. And we can do so much more. And the patient is reassured that what she was convinced with all along is that I have a genetic condition now has an affirmative result. Next slide, please. So in summary, renal genetics and transplantation, advances in next generation sequencing have made genetic testing more accessible. It's allowed us to improve the accuracy of diagnosis, to improve access to treatment for primary diagnosis and transplant planning for recipients. It's helping us to guide donor selection, and there is that prospect of personalising care for patients with inherited kidney conditions. And there is an increasing role in kidney transplantation, which is inevitable. So my role is to help develop understanding of genetics amongst nephrologists, as a mere nephrologist myself and not a geneticist, but to then make it more accessible for our patients and therefore to apply it in all fields in nephrology. Next slide. So that's it. Any questions? Yes.
I have 2 questions actually. One is that what you did in your second patient was basically a cascade testing. So in these cases, like right now, aren't you using the whole genome? Like in UK right now, the whole genome is being used more and not the whole exome, right? Like you are using the genome, and in genome normally we would get such deletions. So what is the norm right now? Like, are you going with a whole genome background or you're going with a whole exome background?
So it's a whole genome sequencing, and it was actually in 2022. But what it allows us to do is to look through. I mean, there are only relatively few reads in the whole genome sequencing of 100 to 200. Sometimes it's whether or not we're doing enhanced reading, as we do with TS, because it's a slightly more complex gene and there's a slightly higher prevalence of mosaicism. So if you've got 1 to 2% mosaicism, then 100 to 200 reads is only going to pick up 1 or 2 findings. So if you do enhanced reads, you're more likely to get
the CNVs will get more, and like we can actually detect more CNVs if we do an enhanced read.
But of course that's not widely used in.
Okay, so in general you are still doing a cascade testing. You are first giving the basic one, and then if needed, then you are scaling it up to the higher.
And And the problem is that we have a number of patients who are coming with no family history, with cystic kidney disease. The genetic scientists may be blind as to how very characteristic their ultrasound or MRI report might be, and therefore they haven't got enough information to say, should we go and invest in enormous amounts of time in just testing and testing and testing this one patient. So our role is then to ensure that the HPO terms, the human phenotype ontology terms, are accurate, that we make sure that before we tested, we counsel the
clinical
patient
diagnosis
appropriately.
is as accurate as
Absolutely.
possible. Yeah. So my second question is something to do with that only. So in cases where we are getting no genetic report, because we know the highest can be 60%. In 40% of the cases, even if there is a family history, we still might not get a variant. In those cases when the cases come up for transplant, so what would be your counseling and how would you proceed with that?
Oh, well, that is wonderful, and I think we just have to be very bespoke about it. We have to recognise, and so I think that when we're convinced this is a genetic problem, we don't have a genetic diagnosis. We know that it will come at some point, but we don't want to prevent them from proceeding with transplantation. Then we're I think dealing with risk, really, aren't we? Predominantly with the risk of a parent or a relative also having a similar condition, and there are some that would like to donate regardless, and there are others who would rather shy away if the risks are too high. So it is very, very bespoke. But of course, the more that we involve everyone in the discussion, the more likely everyone would have come up with the same answer.
Yeah. So in these cases, do you actually have a medico-legal, because it can also lead to a medico-legal issue. So do you actually have any kind of medico-legal protection or any kind of form or disclaimer that you give to the patients to say that, because there are some cases like, say I'm 20, I want to donate, I might get a disease at 40. So, which I am not thinking right now. So, is there any kind of, like counseling, I understand, but any kind of medical legal protection that you are taking as a second level?
I think not over and above our hospital legal protection, but we do, as a hospital, pay quite a lot of money to the legal department for protection, and we document everything as clearly as we can, and the consenting process is as inclusive as possible. And I will regularly be in touch with Richard, with Janet, about various cases that where we're not sure. So it is very much our transplant donor workup physician who is taking on that risk, taking on the information from all of us, whether or not we're geneticists, nephrologists with an interest in genetics, and assessing, also whether or not they have they're going to with the right reasons behind it.
And one very small question. I don't know whether it's a valid question or not. With PKD1 and PKD2, often we get a second mutation. Like there is a pathogenic one, and then we get a VOUS, which in many papers right now is saying these spontaneous mutations are also modifiers. And when we test the family, sometimes what happens is that the father, there's a lineage, but the mother probably has the VOUS and she still does not have the disease. So in these cases, picking up donors, would you use the VOUS, would you use the mother's kidney, or you will not?
Just pushing. I think the answer is probably not, just because we're going to struggle medico-legally, aren't we, on that basis. I can think of one. We could go on. We should probably talk after.
Yes, please. Yeah.
One ADPKD1 and HNF beta in mother that we got from South India. And it was a very complex interaction, and ultimately the mother could donate because she is less riskier donor. So Madhu.
I think in these cases being bespoke, like you have to give out all the risks and like this.
I will actually bring this to an end because poor Victor is
Yes.
past midnight. Yes.
And it's nice that we were not prepared, but Narayan dealt with the CGN genetic disease and he dealt with cystic and CIN related genetic disease.
Brilliant.
Thank you, Nick. It was a very nice lecture.
Thank you very much. So we will move on to a completely different topic, and I just wanted to make sure before I introduce the topic that you're sharing the screen with Victor. Is that right? Can he present? So Victor, if you could share your screen, that would be great. Now, I'm a kidney doctor, but it's a pleasure to introduce this whole topic about cardiorenal and cardiokidney metabolics. And I'll tell you what will happen in the next 1 hour or so. We have amongst us Dr. Victor Hugo Gomez Johnson, who's going to be speaking from Mexico City, and he's a kidney doctor. He will be talking about the cardiorenal clinic in Mexico City, followed by Dr. Isaac Chun, who's also a kidney doctor, and he will be talking about the cardio-kidney metabolic service in Southwest London. And then we have amongst ourselves actually a cardiologist, Professor Subra Banerjee, who's going to talk about the proposed cardio-kidney metabolic care in the Indian setting. So, Victor, are you sharing the slide? Can you hear me? Can you speak, Victor? You're on mute.
Hello? Can you hear me?
Victor, can you speak? You're unmuted, I think, now.
Can you hear me?
Yes, we can hear you very well. And can you share your slide?
Okay.
So as I mentioned, Victor is actually a kidney doctor speaking from the National Institute of Cardiology. So he works in a hard place, but he's a kidney doctor. And there you can see him, and he's going to share his experience about cardiorenal care in Mexico City, in Mexico. We can see you very well, Victor, and I'm sure you're trying to share your slides now. And whilst he's doing that, just to give you why we have chosen this topic is, diabetes is on the rise, and obesity is on the rise. As a result of which, obesity and diabetes-related kidney disease is on the rise. And when you put the diabetes, obesity, and kidney disease together, what you can see is the heart disease is on the rise, and it's going to be a major epidemic, not only for we're talking about the United Kingdom and Mexico City here, but also in India. So we need to all understand how we're going to tackle this epidemic. How are you going to make sure that we provide care to these patients, which will be numerous across different countries, different continents. How are we going to provide? What will be the model of care? Who's going to be managing these patients? Will it be a kidney doctor? Will it be a heart doctor? Will it be a diabetologist or obesity expert? Or is it all of our responsibility to take care of them? The other thing we should not forget is these patients do suffer quite a lot because they move from pillar to post. They go to a kidney doctor, they're prescribed medication, then they go to a heart doctor, those medications are stopped, and they also have a primary care physician who is obviously looking after them and prescribing their medication. So these patients really travel between doctors quite a lot, as a result of which their care is often poor and they don't get the medicines they need to help them to survive longer or perhaps have a better quality of life. The other thing to emphasize, again, Victor, I'm just speaking because you are trying to share and we haven't been able to see your slides yet.
Yeah, I'm trying to share the slide.
Ask him that whether he finds the
Let
share
me
button.
see.
Can you see the share button?
Okay, it's because I'm trying to share, but okay, let's see if this can work out.
Yes, you have started presenting. We can see your slides. If you can put it on presentation mode, that will be great. But if you can't, that's also okay. Yes, I think
that's it, right?
Okay, Victor, you have been introduced. Thank you very much. I know it's past midnight for you, so sorry to keep you awake. And
Oh, don't worry. Yeah, thank you. Well, thank you. Sorry for the delay. I struggling with the sharing of the screen, but yeah, I will talk about the implementation of care in heart failure and chronic kidney patients. And I'm the head of the cardiorenal clinic here in Mexico City. So, okay, so why this topic is so relevant? Well, because obviously most of our patients they mostly die because of cardiovascular disease, and we can see here in the USRDS report in the 2020, we can see that every patient with CKD, regardless of the stage, it would basically would die because of heart failure, coronary artery disease, or acute STEMI, right? But as you can see here, the coronary artery disease and the heart failure are almost the same one. So I think the heart failure patient with CKD, it's a really, really important patients to be, so we can treat about them. So this is a kind of new study of Liz Anderson, that it's a great cardiologist of the Revolution Heart Failure Study. So they screen for heart failure with shortness of breath and BNP over 300, basically for 6 years, and they were almost 6,000 patients. So they found that almost 60% of the patients have chest shortness of breath, sorry, and almost 50% of the patients have CKD. So that's a big amount of the patients. And as we can see here, as the higher the NT-proBNP level, it's the own cause of death and also the heart failure hospitalization. So now we can see that the patients with heart failure, most of them will have some degree of kidney disease, and the higher the level of the NT-proBNP will be worse for the patient. And obviously, patients with heart failure and CKD, they cost a lot of money because they tend to be in the hospital a lot of time, and a lot of the frequency of the visiting of the ER department, it's really, really frequent. So they cost a lot of money to the countries. So can we do something? Yes, of course we can do something. We know that there are a lot of treatments that can change the outcome of these patients. We have more evidence of the patient with HFrEF, the reduced ejection fraction, but also right now we have also a lot of evidence of decreased circulation reduction. So obviously we can do something with these patients. So this is basically what maybe most of us would have done in the past, that the sequencing of the GDMT starts on the patients, and we tend to lose a lot of time doing this sequencing, but we should do it the rapid sequencing, right? When the patient gets hospitalized in the inpatient heart failure, is we know that we should start the 4 treatments for the patient, and they get discharged with these 4 treatments, and in the outsetting hospital we should titrate as tolerated to the maximal dose. So this is obviously a study that has done in the past. That is from the strong HF study. It is over 1,000 patients, and they try to evaluate the early changes in the renal function during this rapid up titration of the GDMT treatment. So all of the patients, they were admitted because acute decompensated heart failure. They were randomized to intensive up titration with the treatments that we know, or the usual care. The high intensive group, they were over 500 patients. They would have the full GDMT dose within 2 weeks, and the follow-up was 1, 2, 3, and 6 weeks and 90 days. And the usual care patients, they have the usual up titration by the physician. And we can see that in the start of the week 1 pre-randomization, we have the same level of the EGFR. But in week 1, we can see that obviously the high intensive group, they have a kind of a decrease in the EGFR, but as we can see by the end of the study, the 90-day, we can see that the EGFR goes close to the usual care, and these patients have already the maximized dose of the 4 pillars of the treatment. So this is a thing that we should do for all our heart failure patients, and we can see that despite this kind of decrease in the EGFR, it would be no problem by the end of the study. And we can see now here also that these patients were, we have here in the blue line that if they have a 15% decrease, and in the red line, they have more than 50% of the decrease in the renal function, despite the curves are kind of separated, they have no all cause of, they didn't have a big like bad outcome at the end of the study. So we can see what I tell the residents when we are up titrating these medications is that maybe we should know that the renal function will be a little bit worse at the beginning of this up titration in this kind of aggressive way, but we know that we are giving the full benefit of the patient and we can maximize the full dose of the GDMG treatment as well. So I think personally that despite all these big studies that have done the creatine, the DAPA-CKD, the IPGMER, we can see that obviously these kind of treatments, they allow us to decrease the proteinuria, the albuminuria, and also with impacts obviously in the outcome of the patient. But maybe we should start in this gap of the patients. Maybe we shouldn't wait to the patient to have an EGFR below 60 or a severe albuminuria. We should be more aggressive, in my humble opinion, to maybe start these medications when the patient hasn't arrived to this kind of the heat map. Maybe we should start earlier. And we know that of the DAPA-CKD and the EMPA-KIDNEY studies, we know that despite the kind of this slope in the EGFR, we know that the patient with a lot of albuminuria will benefit a lot of these medications. So what's the reality of this kind of studies? We know that in this study, they kind of try to demonstrate the underuse of the, for example, the MRA in the heart failure patients, and this is a big registry from Sweden. And we know that there was very limited use of the MRAs, even among patients with an EGFR of 30 to 60 ml minutes. The MRAs were rarely prescribed, and we should be really confident to use this kind of medication with this EGFR. And the conclusion of all these big studies is that the MRAs were not used, basically were not used when the EGFR were below 30 and the serum potassium was above 5. So there are a lot of kind of barriers that we are putting ourselves to improving this kind of care to the patients. So this is another study that is the evolution trial, and what I like about this is that they screen for patients that were hospitalized for heart failure, and after this hospitalization they try to see, to screen how many of these patients were in the 4 pillars of the heart failure treatment. And we can see that this was done in really high-income countries like Japan, Sweden, and the States. And we can see here that in dapagliflozin, SACMAL, ACE inhibitors, etc., we can see that since the heart failure discharge, day zero, most of the patients, they kind of started, yes, some of the medications, but when all the lines get like combined, it's like 150 days, 200 days since the last heart failure hospitalization. So basically, we're starting really late these medications after the hospitalization, and we should try to avoid that. This is another figure that I really like, that as we can see the times since treatment initiation, we can see that most of the patients, despite every medication, they kind of discontinue the treatment. ACE inhibitor, IRB, beta blocker, MRA, most of the patients have discontinued treatment along the time. But also, most of them were in the intermediate dose, not even the high dose. So this was done in really high-income countries. So imagine that if we can see here, like in Mexico, that we are struggling in the public health system, this registry would be worse here. So we should avoid discontinued treatment, and we should try to aim to that the patient after hospitalization, they have to be with the 4 pillars. Because we have this scenario, we have most of the patients that are above 30 of the EGFR, we are really easy to start the medication, but as the EGFR falls, we kind of be stuck, and we try, maybe we are restricting the patients of all the medication that they should be with, and also because there are not much evidence of these medications in, for example, in CKD cadena 5. So basically, we have this like a kind of heart failure with a kind of healthy kidney, they are obviously prescribed preferred medication. But as the kidney starts to failing, these patients by the start they are not being prescribed by the MRA, and when they are in renal replacement therapy, it's worse. They only get the beta blockers, so these patients are excluded from the trials and they are excluded for the treatments. And we should aim to treat all these patients equally. So this was a study that was done by Prof. Banerjee, the LIFT trial, that I really like this study because they use this potassium binder to try to maximize the RAS inhibition. So they were heart failure with a reduced ejection fraction patients with an EGFR of below 60, with a peak was 31, the potassium of 5.5. And the primary outcome was the comparison of the sodium zirconium cyclosalate versus placebo for the RAS inhibition optimization. So basically, they did this, right? They randomized these patients and they start the ramipril, check potassium, spironolactone, the MRA, and then start the Lokelma. So we can see that this slide was courtesy of the Prof. Banerjee, that in the intervention group, in the red bar, we can see that the maximal dose of the whole RAS inhibition without the potassium you can achieve that. These kind of potassium binders, they can help you try to achieve the maximum dosage despite the grade of the CKD of the patients. And I really like this figure, obviously also of Prof. Banerjee, that we can see that in the placebo group, there are a lot of lines. What I try to draw, it's like how many patients there were above 6. Like above 6, we are really scared. As a nephrologist, we are really scared about the potassium above 6. With the Lokelma, really low. But if we can see of the 5.5, that is the most value that these patients have, and they get restricted for the RAS inhibition, we can see that a lot of patients in the placebo group have above 5.5, right? So I think that there are a lot of strategies to try to include all these patients, regardless of the EGFR, to be maximized in the whole GDMT treatment. So can we measure the GDMT treatment? Yes, we can. This is a study, a postdoc study of the heart failure collaborative medical therapy, that they try to score like all the pillars of the GDMT treatment, and they prove that the higher the score above 50, you can have less hospitalizations and even less cardiovascular death. So we can measure and we can try to use this treatment score for the optimization of our patients. This is also another proposal of another score, that is the GDMT treatment score, that also tries to put some values to the maximal dose of all the pillars in the heart failure patients, and the higher the score is, the better the outcome for the patient. So what about the cardiorenal clinics? Well, obviously we know of this study of Prof. Banerjee, one of the first reports of the cardiorenal clinic in London at St. George's, and we can see that they were over 100 patients. They have a lot of heart failure with reduced ejection fraction, but also with preserved ejection fraction. The EGFR was 31, the ejection fraction mean was 38, the potassium was 4.6. And what they prove is that this management of this interdisciplinary clinic, we can these patients have more of the RAS inhibition after the last visit. So these cardiorenal clinics, maybe they till today they do not impact in mortality yet, but I think that we are trying to aim in is to reduce these hospitalizations and try to put these patients in the correct medications and maybe try to avoid these bad outcomes. This is another recent study of the Spanish people. They have a big cardiorenal clinic. It's like the first study to like kind of a descriptive study. They have over 1,000 patients. But you can see the EGFR, the mean of the total sample was 52, so really good GFR. You don't have any problem to give any of the GMT treatment with this kind of EGFR. They have really good potassiums. The ejection fraction, the mean ejection fraction was 42, so kind of not that sick patients, but they have a lot of patients. And they try to put in these bars of the how many of the patients try to, according to the EGFR, how many percentage of the patients have all the medications, right? And we can see that the quadruple therapy, when the patients have lower than 30, it's only 30% of the patients have the 4 pillars of the treatment. So this is a problem, and we should try to aim for that. So, for example, example, this is an unpublished data that we are about to submit. We compare the cardiorenal clinic from Mexico and the one of the Prof. Banerjee at St. George's. And we can see here that this is the data in the UK and the data from Mexico. And you can see the age. Our population is really young. We have really young and sick patients. We have the UACR pretty the same, a lot of higher BNP, and ejection fraction, it's a bit lower, and that explains also the higher BNP. The eGFR of both clinics are pretty the same, 30 basically. The more heart failure with reduced ejection fraction here in Mexico, like 80%, at least in our cohort, and a lot of atrial fibrillation in London. And basically, we have more or less the same degree of the CKD stage in both clinics. So we can see here in the baseline with how the patient arrives in the Mexican cohort and the UK cohort, and they have a lot of SGLT2 inhibitors, MRAs basically 50%, here 24%, beta blockers pretty much the same. When we try to analyze the follow-up, both clinics uptitrate really good the medications. No? I think, and we talk about with Prof, maybe these numbers, if we can see only looking at the figures, are maybe kind of more blue, right? More in the high dose in the Mexican cohort. But we think obviously that's because our population is basically heart failure reduced ejection fraction, right? So that's kind of a bias in this study. But we can see that most of the patients can have these good high dose medications regardless of the country you are, independent if it's a high income country or a low income country. And this is another table that is of our clinic here in Mexico, and what I like about this is like only if you look at this one, the medication, when they have the 4 pillars in the baseline, 57% of our patients are already having the 4 pillars, so we can do that. So that's pretty achievable regardless of the country you are. So what's the goal of all the studies and cardiorenal clinics? We can try to use this study as an example, the SMART C, that is a good release study. We can see the CKD progression. If we focus only on the CKD progression, patients that have the SGLT2 inhibitors, the GLP-1 receptor antagonists, the non-steroidal MRAs, look at this graphic. It's pretty amazing. So basically, when they presented this study in cardiology congress, they talk about like the CKD progression and the CKD of the disease of the CKD, maybe more of a risk factor than a disease if we use the correct therapy. So we can do that, right? We can try to slow the slope of the eGFR to maybe try to aim to the aging, right? Like the mean loss of 1.2 per year. And if you use the correct medications and if we have maybe some problems with the potassium, we can use Lokelma or any other potassium binder. So we can achieve that, and we can maybe try to aim to the slope of the eGFR, try to be more closer to the aging, right? So my personal conclusion is that there is an invariable relationship between cardiac and renal pathologies. The evidence strongly supports treating both conditions as a single clinical entity. We should not wait until the eGFR falls below 60 to initiate the full quadruple therapy. The use of potassium binders may help us optimize the RASi therapy. Preventing hospitalizations is as important as reducing mortality because of the cost. And maybe the cardiorenal clinics contribute to reducing hospitalizations. We don't know that till today, but I think that's the aim of most of our cardiorenal clinics. So I really appreciate that to inviting me here. There is my email, by Twitter, anything you want to ask me. I'm really fully happy to answer.
Thank you very much. So we will take maybe 1 or 2 questions. Please, sir. Oh, sorry. You can hear me. Orbita, go ahead with your question.
So, thank you, Dr. Victor, for joining in such an odd time with us and giving your valuable introspections and sharing your valuable introspections with us. But I would let you know, really, we are trying to put these heart failure patients to 4 therapies sequentially so that the hemodynamic AKI does not threaten us that way that they stop taking those medicines, but the pressing limitation is still hyperkalemia. In India, resource limited, we cannot put them on anti-hyperkalemic therapies that commonly, because whatever anti-hyperkalemic therapy we have, we all are costly. We try to make a judicious combination of furosemide or chlorthalidone, group of diuretics, keeping in mind the perspective which stage of CKD they are, and try to cross over this pressing limitation of hyperkalemia. Sometimes we succeed, sometimes we not. We need to withdraw that. That is the situation in India. We will greet sodium zirconium, of course. It's not still available, or any other costly anti-hyperkalemic therapies like Paciromar, but I am doubtful that how we can implement it for the common good.
Well, for example, in the public health system in Mexico, the Lokelma, or well, we only have Lokelma in Mexico, but it's not really easy to have Lokelma because it's kind of expensive, right? We can use it in the private health system, but in the public health system, it's really difficult. But what we try to do in our clinic that is in the public health system is maybe try to help us out with a little bit of diuretic. We use a lot of the ultrasound in our clinic, so we do obviously the physical examination, but also use the ultrasound to guide our diuretic treatment. So we found that most of the patients, maybe they do not have rails, they don't have edema, but when we put the ultrasound and we evaluate the whole thing, we do find kind of the data signs of overload. So that's why we also do that, and we use a lot of more diuretics in Mexico, right? And I think it's because we use a lot of the ultrasound, and we found this kind of a subclinical congestion, and we try to avoid that. So I think our cohort, it uses more diuretic than the cohort of North London, and that's because we use a lot of ultrasound, and that's also why we can have a lot of the patients with MRAs with EGFRs below 30 with a nice potassium, because we use a lot of diuretics. So I think that Mexico and India kind of look alike in a lot of ways, and in the public health system maybe there's a lot of similarities, and we try to use a little bit of more diuretic. Obviously, there are some patients that may have EGFR of 10, and we do not start MRA on those patients, right? But we use a lot of diuretic, and I think that helps us out a lot.
Thank you, Dr. Victor. I would like to ask you that what is the take of this quadruple therapy in acute heart failure, and how do you titrate that? Acute heart failure, this quadruple
In acute
therapy.
Yeah, when we have acute decompensated heart failure patients, we obviously do the physical examination, and we try to dose the diuretic based on the ultrasound also. So we have this patient, for example, that arrives to the hospitalization with really bad congestion, clinically and with ultrasound. We use diuretics, but from the start, we use the SGLT2 inhibitor from the start. We drive the patient, and when the congestion, it's a little bit not severe, but moderate, maybe not eubulimic, but it's more moderate by the ultrasound, we start some of the GDMT treatment. It's not like based on hard evidence, but we use, for example, based on the EGFR. If the EGFR is 15, we only start the beta blocker on a low dose. If it's 15 to 30, we start with ACE inhibitor or SACPA, Entresto. And if it's below 60, above 60, sorry, we use everything. So we most of our patients, when they get hospitalized because of acute decompensated heart failure, all or most of them, they get discharged with the 4 pillars, and they get the first visit to the cardiovascular clinic, a really close visit, like a week after the discharge. So we start to titrate really quick. But yeah, we are really aggressive with the decongestant here in our institute, and we start the GDMT treatment really really quick, and we gave the patient an appointment really a week after the discharge, so we can obtitrate really quick.
Thank you very much, Victor. Any other questions? If not, we'll move on to the next presentation. Victor, if you could stay on, that's great. If you can't, I know it's probably past midnight. You can log off as well. So Isaac, can you please share your screen if you can and do the presentation?
Hello.
So while Isaac is coming on, saying thank you, Victor, because you emphasize that we have medicines. Physician inertia is a problem. Rapid titration is good. You have shown evidence from strong heart failure studies.
I'm sorry, Prof. Ban, you're muted on Google Meet.
Am I? Sorry, you can't hear me. Can you unmute me for a minute, please? Can you hear me now, Isaac?
Yes, we can hear you now.
No, thank you. So it's a pleasure introducing Dr. Chung, who is going to talk about the cardio, kidney, and metabolic care in Southwest London. And by way of introduction, Isaac is an academic trainee. He's actually a general medicine trainee now, but he knows a lot about cardiovascular disease and chronic kidney disease. Isaac, over to you. Can you please share your screen? Thank you very much, Isaac. You can start. Yeah, Isaac. I'm muted here as well. Okay. But he can't hear me because I'm muted. Okay, Isaac, you are muted.
Yep. Can you hear me?
Okay, thanks.
Thank you for the introduction. I'm here to talk about the Cardio-Renal Metabolic Clinic in Southwest London. It was started by Prof. Banerjee, Dr. Ants, and Dr. Chen, nephrologist, cardiologist, and endocrinologist. It was started because there was recognition that even within the cardio-renal clinic, there were lots of people who had poorly controlled diabetes who often need all three specialty input, and it was quite difficult to coordinate it between different clinics. It may be better to make it all in one clinic. And before we talk about it in Southwest London, we can see that around the world there has been quite a few efforts to try and unify this. So here, this is a busy slide, but this is a way of managing cardio-renal metabolic patients that was started in Montreal, Canada, and they had their paper introducing their clinic in 2022. Their clinic is a bit complicated, so patients are generally referred by their clinicians, by their primary care physicians in Canada to the clinic, and at the clinic you'll be seen by clinic nurse and then by a physician specialist who is usually their cardio-renal metabolic fellow. Using the information into this, they would then triage the patient to a single specialty. So what they've said is, if someone's main problem is heart failure, they would be seen by a cardiologist first. If someone has a fully controlled diabetes, then it would be seen by endocrinologist first. If they have their main problem is CKD, they will be seen by nephrologist first. Once they've seen that single specialty, that specialty physician would then take it to all three specialties to have a discussion, like a mini MDT, then make a plan about what they would do in the future. Afterwards, the patient can come and see all three specialties together to allow them to ask questions, to agree the plan together. And in this clinic setting, they would have 2 more appointments to allow them to optimize all their medication. And afterwards, they'll be referred back to their own care. So this would allow them to manage all three conditions at the same time, and reduce the clinic appointments that patients have to face. The other method, which was trialed in Liverpool in the same year, 2022, was that they tried to do a virtual MDT. This is a much more comprehensive MDT. So normally, patients would be referred by a specialty doctor usually, who would fill in a form about all their problems and identify key areas where they want the MDT to give input. Within the MDT, there are a lot of different people. So you can see there are cardiologists who specialize in heart failure, then there are specialist nurses, there's a nephrologist, there's endocrinologist, there's a palliative care specialist, there's a chest physician, there's a geriatrician, there's a pharmacist, and there's also a pharmacologist who's a doctor who usually specializes in managing medication. And the main focus of the MDT is to try and manage all of their pathology in one go, managing both guideline-directed therapy for heart failure, but also frailty, respiratory conditions, and fall risk, whether there's any cognitive dysfunction, whether there's any way to reduce their medication burden, and also advanced care planning and palliative care discussion. They would then finish their discussion and send their recommendations to the referrer, who would discuss the MDT results with their patients. And they have shown that in 334 patients, they've managed to reduce hospitalization, reduce outpatient attendance for their patients, and have a cost saving of £600,000. So I think it is quite clear that there is an imperative to be more cross-specialty working and to make it so that patients don't have to attend multiple clinics and save money in that way and optimize their care. So in that way, in Southwest London, what we've done is we've applied for a grant from our hospital funding for 2022 to allow us to set up this clinic. We saw our first patient in May 2024. This is a photo of one of our clinics during that time, where we have our endocrinologist, our cardiologist, and our nephrologist all managing. We also have a heart failure specialist pharmacist attending, who helps us manage some of the medication issues around these patients. In November 2024, we also have a more novel idea about going to their primary care physicians to do MDTs, to help them understand the problem and to discuss patients within their premises, which I'll talk about a little bit later in the slide. And as of now, we have discussed 111 patients in our hospital CRM clinic, and we've done 4 GPMD. We've done 4 MDTs at the primary care physician, which are the 4 GPs in the UK. So focusing more on the hospital side, so looking at the hospital, the majority of people out of 111 patients, most of them were referred for weight management reasons. The second main reason they were referred was diabetes, and the third reason was heart failure management. We do have some more rare referrals for specific cardiac screening, for kidney transplant, and also difficult to manage lipid management. In terms of referral sources, most of our referrals come from nephrologists and cardiologists, with a small section coming from GPs and cysts. And quite a few of them also come from our joint clinic, that's cardiorenal, and a small selection from endocrinologists and some community referrals from the outside the hospital. Our population has a mean age of 67 years old. Majority male, majority with diabetes. A little bit less than half have some ischemic heart disease. They generally have a relatively low eGFR, with most of them sitting at CKD stage 4. and the majority would have heart failure with reduced ejection fraction, with the second largest proportion having no heart failure. And as you can see here in the diabetic status, the majority of people have diabetes, but also a very large majority of people have a BMI between 30 and 35, which is not surprising given that the majority of the times they refer to weight management. The HbA1c, the mean HbA1c is 58.04, which is not too bad. So the majority of people we see in the hospital CRM mainly have CKM stage 4, as and with a very small amount of CKM stage 3 and much smaller CKM stage 2. So the way the clinic works, essentially we try and receive the referral, then 4 3 clinicians would look at the electronic health record, look through their notes and blood tests, and discuss their case. The majority of the work each specialty focuses on, for example, renal would be mainly focused on reducing disease progression, prescribing disease-modifying drug, considering CKD management like IV iron or venetoclax, and in this case, given that a lot of our patients have CKD stage 4, considering liver replacement therapy, and organizing this the workup for transplantation. While cardiology similarly wants to maximize medications and can give cardiac screening recommendations if people need a kidney transplant or happen to have a complex cardiac history, while the endocrinologist is able to advise us whether GLP-1 is recommended for weight loss in their case and whether they should have continuous glucose monitoring like freestyle glucose or Dexcom. And once we've reached a consensus with the plan, we would call the patient, and that would allow the patient to feed back to us what their priorities are and how the plan can be made to suit their priorities and to make sure that they agree. And once we've done that, we usually would prescribe the medication ourselves and then organize the test, and then we'll send a letter to the patient and GP to confirm the plan and to make sure that the long-term plans for several months get followed. So the goal of all of this is so that we want less repeat appointments, so they don't need to attend an endocrinologist and then go to the renal clinic and then go to the cardiologist. By allowing this discussion between all 3 specialties, we hope to maximize GDMT as quickly as possible, and hopefully that would reduce cost to admission, and especially for more complex and high-risk patients, discussion in real time would reduce a lot of the admin work of letters between different specialties, but also help reach a good understanding between all 3 specialties and reaching decisions for these patients. However, as we can see from the CKM stages, we see mainly very high-risk patients already have heart failure and have CKM stage 4. So at that time, what we thought was that we could go and see patients who are less high risk, who are earlier in their sort of patient journey in renal metabolic, and we thought that the best place to do that would be with their primary care physicians, where we can catch them earlier and hopefully intervene and reduce them worsening. And here we have 3 photos of where we went to their primary care physicians. So stone pot surgery is a primary care physician surgery that's about an hour's away from our hospital, and graft medical practice is similar primary care physician that is located actually only a 5-minute walk away from our hospital. And Dr. Vasa Ganas is here, and Dr. Azar is here. They're both primary care physicians who know their patients very well, and they bring us patients and we discuss them in our GPM meetings. So because we've done a bit less, and also because electronic health records between hospital and these primary care physicians are different. We have fairly limited data on these people. We've only got data on 31 of them we've discussed, which is only actually two of the GP MDTs that we've done. So they are a fair bit older. There's a majority male, with a little bit less of a majority having diabetes, with less having ischemic heart disease, and some and the EGFR is mixed, as you can see. The majority of people are in CKD3A, and they have heart failure. Most of them have heart failure with reduced ejection fraction. And actually, the majority of patients we discuss don't have diabetes in these GPMDs. Here, we still have a fair majority being in CKM stage 4, but we have much more people in CKM stage 3, and some people in CKM stage 2. So this GPMDT works slightly differently. The GP brings us cases, and all of us discuss the case from the electronic health record, and we make a comprehensive plan. We have very similar objectives. We're trying to maximize the guideline medication to consider treating complications of CKD. We're trying to treat and manage their blood glucose as best as we can. We're considering GLP-1s and considering how we can help them lose weight. There's a lot more consideration around advanced planning and trying to pre-prescribe if possible. And then once we've made the plan, the GP usually actions the plan within the week. And we think leaving the GP, who often knows the patients very well, is probably the best way to allow these discussions to take place, especially around advanced planning and prescribing. And because they know the patient so well, they will also be able to persuade them to take medications that they may not otherwise be willing to take. So here, the other goal that we also have, because we're discussing these cases with GPs, we're actually doing some interprofessional teaching at the same time, and allowing them to probably manage patients who are much lower risk, with a lower complexity by themselves, and hopefully reducing our hospital clinic burden, lengthening these clinic appointments of patients who might need them more in the hospital, and by allowing more prescriptions and guiding and directing medical therapy, we're also hoping to avoid hospital admission. So with these two methods of both having either going to their primary physicians and having MDT or having clinic, I think the question is like, which of these is actually the best way for us to treat these patients and reach a good, comprehensive plan with these patients and maximize their therapy. But there are other things that are being done at the same time. Here is a traffic light system from a patient-led heart failure charity that we know quite well. So encouraging self-management is really important, because patient know themselves really well, and probably they're the first people who can alert us about if they're feeling unwell and that they need help. The other thing that we're doing is we're trying to do more education around the community about the importance of cardio, kidney, metabolic syndrome, that there are ways to help these people, and that they are complex. They do require multi-specialty input, but there are things that you can do to help these patients achieve less hospital admissions, reduce mortality over time. But also, finally, in terms of society, there are mechanisms that are already being done. In the UK, we've started charging a sugar tax to make it more expensive to have very sugary drinks like Coca-Cola. So you can see there's a 10p difference a bottle, and that's because since 2017 we've started charging a sugar tax. I hope this explains the things that we've been trying to do over the last 2 years. That's my email, and I'm happy to answer any questions.
Thank you very much, Isaac. Thank you. Any questions from anybody?
I like to say hello to Isaac. Hello Isaac, Arpita here.
Hello.
Hello.
We met in St. George's days.
Yes.
So, very nice talk, very encouraging, and the last slide is most appropriate for my young students because they indulge a lot on your sugar in cola.
Actually, let me ask you a question to the audience. Who believe in a sugar tax? Who wants to pay a bit extra if you buy full fat or full sugar Coca-Cola versus zero Coke? Raise your hand. I believe in it. 1, 2, 3, 4, 5. Majority doesn't. This is the amazing thing. So majority like to drink full sugar Coca-Cola rather than normal Coca-Cola. But look, as a society, we have a responsibility too, because there will be a tsunami of cardiovascular metabolic syndrome, and we need to do something in the society. Nick, did you have a question? No. Subro has a question. Subro will be the next speaker, Professor Subro Banerjee, and he's a cardiologist. So we have a cardiologist amongst us, and he has a question for Isaac.
Hi, Isaac. It was a great talk. You can hear me? Yeah, this is Subro Banerjee.
Yes.
Now, I think I agree with you, and that's really important, that we have to focus on the stages 1 and 2.
Me too.
I mean, when it's 3 and 4, the CKM stages, I mean, we are far advanced. So that's one. And secondly, most important players in this field, I think, are the primary care and the primary care physicians, because that's when things start. So if we can catch them early, and so it's our duty to make the primary care physicians aware of the CKM syndrome, and if we can stop it there, simple things like about why we should eat a lot of sugar, what's the necessity for doing exercises. So this starts with the primordial prevention, and I think that should be the future of CKM care all over the world. Thank you.
Thank you, Subro. I completely agree.
Obesity reduction.
Obesity reduction. Well, if you exercise and eat less sugar, obesity goes down. So, can I now invite Subro? Subro, if you want to come onto the podium. And is your presentation ready, Subro?
I hope so. Is it?
So, Professor Subro Banerjee is a cardiologist, and he works at the Apollo hospitals. He has a long-term interest in the overlap between the kidney and the heart. And his talk would be mainly highlighting what we need to do in a setting like India, managing the tsunami of cardiovascular metabolic syndrome. Subro, do you want to start while your presentation is coming on?
Yeah, so good afternoon. Thanks for inviting me here. I have a little bit of pain in my neck, so that's going to be a little bit difficult for me to face the slides, but I'll manage it from the other side. I think, yes, this is an important subject which has been very much neglected till recently. The subject of CKM or CRM, whatever you call it, cardio-kidney metabolic or cardio-renal metabolic syndrome. And we know now that the components, that's components like, it's not only just hypertension, diabetes, and the kidney problem. It's also like obesity, and these, So these things are actually very important, and they have to be taken care from very early age, so that we do not develop this syndrome in the first place. Okay, so can I change the slides for you, or use their pointer? Okay, so you're going to change the slides, right?
There is a slide changer as well, no?
Okay.
Oh, yeah.
Slide changer. Oh, that's right. Hang on. Okay. So. Okay, so what is cardiorenal syndrome or cardiovascular kidney syndrome? Well, in brief, it's a health disorder attributable to complex interplay among obesity, diabetes, chronic kidney disease, and cardiovascular disease. And these diseases have shared risk factors, shared pathogens, and shared therapeutic options. And other comorbidities may often exist, such as MSLD, cognitive dysfunction, obstructive sleep apnea, pulmonary disease, and even cancers. Now, while each of these components of CKM is associated with increased risk of mortality, the risk is much more if all the components are combined. And CKM syndrome is a worsening public health crisis with significant mortality and morbidity and economic burden. So therefore, an early detection, integrated preventive approach, and targeted interventions are crucial for prevention of these diseases. It's not working? So if you can, yeah. So these are the components of cardiorenal syndrome, and since it hasn't been discussed since this morning, I'll just quickly go through it. There are 5 stages. So stage 0 is when there is no risk factor for cardiorenal syndrome. Stage 1, when the patient has either excessive or an abnormal adiposity. And what is excessive? Well, of course, you go by BMI, though we know now BMI is not an exact, the best, the measure of obesity. Probably better would be waist circumference or a waist hip ratio or even a waist height ratio. Now, what is abnormal obesity? Abnormal adiposity. That means this is a dysfunctional adiposity. And you would have some features, for example, you can just have hyperglycemia. You could be a pre-diabetic. So what's stage 2 then? Stage 2 is presence of metabolic factors, for example, hypertriglyceridemia or diabetes or hypertension, or it could also be metabolic syndrome or even CKD stage, a patient who has developed CKD. But would be moderate or high risk, not very high risk. Now, next is stage 3, which is actually presence of subclinical CVD in overlapping with the CKM risk factors. And subclinical CVD, as you know, it could be coronary artery atherosclerotic, or it could be heart failure, or it could be risk equivalence. And by risk equivalence, we mean is very high risk CKD, or it could be those who are at high risk of cardiovascular events, and how we find them out is something we are going to discuss later. Or it could be the stage 4, when clinical CVD is present, overlapping with the CKM risk factors. So these are the 5 stages we are going to talk about, and what is important is they have shared underlying mechanisms such as insulin resistance, inflammation, endothelial dysfunction, glucolipotoxicity, neurohormonal activations, and hemodynamic alterations. Okay, so now each of these components of the cardiometabolic syndrome, that's how you can say the component risk factors, there are societal guidelines for managing each of these risk factors. For example, there's societal guideline for dyslipidemia, for hypertension. So the question is, as we have individual societal guidelines, do we still need a common practice recommendation? The answer is yes. Firstly, because we know that the presence of a number of diseases in the CKM syndrome actually increases the risk of morbidity and mortality. But this is something which is often ignored in the societal guidelines. They do actually talk about a particular disease entity, say hypertension or dyslipidemia, but really do not give us some guideline about what to do when a multiple risk factors are present. So presence of a common practice guideline would be important. Similarly, an individual may present to any of the specialties first. They can present to an internist or an endocrinologist, nephrologist, or cardiologist. So, but then the treatment would differ. I would treat him from the viewpoint of a cardiologist, but not from a nephrologist. So if you have a common practice guideline, then that would really be useful so that all the patients get similar treatment. And after all, these patients with CKM would need a holistic and multidisciplinary and interdisciplinary approach. So if you think about it, then of course having a common practice guideline would be really useful. Now, do we need a country-specific guideline? Well, that's also important because each country has its own share of problems and specific healthcare challenges. Now let's look at the challenges in the healthcare system in India and why do we need India-specific treatment. Now, see, one of the difficulties in Indian healthcare system is the delivery of care. And we have to deliver the care to a population more than 1 billion who may be diverse linguistically and socio-economically and spread over a large area. And we do not have the infrastructure to deliver the service. So this is a major impediment or a challenge to Indian healthcare system. And then look about the inequality of the healthcare. More than 70% of the population is actually, they stay in the villages or the rural areas where you do not have anything apart from primary care centers. And here, I mean, these primary care centers, we know they're understaffed, they do not have many of the amenities, and their services are overstretched. Thirdly, if you think about the health insurance, I mean, till some time ago, probably more than 80% of the patients, not probably, this is not the data we have, that more than 80% of patients actually were not covered by health insurance across India. Now, recently, after some state schemes have come in, probably this fraction have changed, but I don't think to a great extent. And the literacy level is also somewhat low, and this resists adoption of, and this resists adoption of changes. And if you look at the level of providers' knowledge, that's also not always what it should be. And there's a gap between providers' knowledge and actually, what is provided. And unfortunately, we do not have strict quality control measures. That also is a major challenge to our delivery of care. And then we know there are two parallel systems operating at the same time. One is the government funded public health services in the public hospitals, and at the same time we have private hospitals where actually the treatment that we give depends on the affordability of the patient, whereas in the government hospitals, such as here, it depends on the budgetary allocation for health. So there are so many different things we have to consider when I have to think about delivery of a care service in our country. Now, if you look at CKM and the South Asians, they are different from that in the West, and why? Of course, how? And of course, we have an earlier onset and a worse outcome. There's a huge atherosclerotic burden. The inflammation and insulin resistance play a greater role in the development of the disease in our population. And there is a high prevalence of hypertension, diabetes, metabolic syndrome, and a unique dyslipidemia, which is characterized by high triglyceride, low HDL, and high lipoprotein levels. And we know that the prevalence of stroke is higher among the Asians than compared to the Caucasians. The central obesity with a normal BMI is also a phenotype which is not very rare in our population. Now, what about the prevalence of CKM among Asians? Well, unfortunately, we do not have any robust data for prevalence of CKM in India. But if you look at the other Asian countries, for example, Taiwan, you will see that with prevalence of CKM increases with age, and above the age of 80 years, CKM of stage 3 or 4 is prevalent in more than 90% of the population, almost nearing 100%. And another interesting thing is, as age advances, the prevalence of CKM 1 and 2, they gradually go down, and 3 and 4, that is the more advanced stages, they actually go up. So if we have to really catch the disease and tackle it, when we have to catch them young. Now, similar statistics you would see in the Chinese population as well. Now, how do you approach the CKM disease? Of course, you have to screen them, that's number one, and then determine the stage, because what you will do depends on the stage, and then you have to predict the risk of cardiovascular events. So risk prediction, and fourth is prevention or treatment of the disease. It depends, of course, on the risk of a particular individual. Now, regarding screening, whom do you screen and what to screen? Now, whom to screen? Your American Academy of Pediatrics says that you should start screening for CKM at the age of 3 years or more. I'm not sure whether that's going to be very practical in the Indian populations or not, but as an adult cardiologist, I would suggest that patients 20 years or more should be screened, ideally, and at least those who have at least one CKM risk factor. Now, what you're going to screen for? Of course, history is very important. History of diabetes, hypertension, dyslipidemia, CKD, CVD. You have to look specifically for symptoms of CKD and not just coronary artery disease, peripheral artery disease, history of stroke and all. And you have to look for risk enhancers, such as chronic inflammatory disease, sleep disorders, sex-specific risk factors, for example, PCOS, or your gestational diabetes. So these things are important. You have to ask about the diet, smoking, alcohol, because it's important for prevention aspect. Social history is important, social determinant of health. For example, I mean, it's not just like what's his income, what's his literacy, what sort of literacy he has, what's the housing condition. So these are all important things. And look at the family history, diabetes, hypertension, CKD, CVD, and then come to the exam. Well, at least the minimum things which you have to do is you have to check the blood pressure, check the BMI and the waist circumference, and look for evidence of any vascular disease or heart failure. That's the minimum thing you can do. And of course, the rest of the examination will be dictated by some of the findings which you have. And then do some tests. Again, the basic test would be a fasting blood sugar and lipid profile, and if also possible, HbA1c. And then, as it is necessary, or depending upon the availability, you can go for USCR, EGFR, FibroScan, ankle brachial index, ECG echo, calcium, coronary artery calcium scoring, or any functional tests of ischemia. Now, assessment of CV risk is important, which I mentioned before, and American Heart Association suggests using PREVENT score to assess a 10-year risk of your cardiovascular events. And the score doesn't only give for total cardiovascular events, but they also let you know, like, what is the chances of getting an atherosclerotic cardiovascular event or a heart failure. And the variables in the scoring system are the age, sex, total cholesterol, HDL, blood pressure, BMI, EGFR, and so on. And of course, there are optional parameters as well. For example, HbA1c and USCR, and there are risk enhancers which could be taken into account in the calculation as well. And this I've already said, like chronic inflammatory conditions, sleep disorders, and so on. Now, this risk score is validated for age groups between 30 and 79, and not to be used as it happens scoring if the patient is already a known CVD or has an advanced subclinical CVD or has end-stage renal disease. Now, PREVENT score has not been validated in the Indian population, but still there are some societal guidelines which say that we can modify the risk by a factor of 1.5, and that would be applicable for the Asians. Well, hopefully that would be applicable for Indians as well, but again, these things have not been validated yet in the Indian population. This is how the scoring looks like, and that's the calculator which gives you this 10-year risk of CVD. And depending upon the risk, you could be high risk, intermediate, borderline, or low risk. And the risk enhancers becomes very useful when you're actually looking at the borderline risk, because they can help you up-classify the risk level. Now, this is important because when a patient with suspected or probable or definite CKM presents to you, well, he can present either to the GP or to the internist or the endocrinologist, nephrologist, or cardiologist. So it's all up to him, depending upon his presenting symptom or as he sees it, as he perceives it, to whom he would present. Now, the GPs or the internist, they usually see stage 1 and 2. Nephrologists would see stage 2 and 3, and cardiologists would see predominantly stage 4. But they can see any stage as well. But the more important thing is, whoever you are, and if you see the patient, and if you think that he has some other diseases as well, then you best also consult or refer this patient to the other specialty as necessary. So that is important. And so coming to the management of CKD disease, well, the management, of course, it has some general measures. For example, lifestyle therapy. We have mentioned about diet, exercise, good sleep, giving up bad habits like smoking, reducing your alcohol. Mental health is also important. And the patient education. The patient needs to be made aware of the disease, and he should know his numbers. For example, what should be the target level of LDL in his case? What should be the level of glucose in his case? What's the blood pressure level in his case? So long he knows these numbers, he himself will be able to pay more attention to them. And there are different validated apps, available on smart phones and tablets, which can help to track the components of his of his lifestyle therapy. Because now the apps tell you how much you have exercised, how much calories you have burned, and that is very useful for yourself. If you will know that you have to lose weight. Now, what sort of also it will tell you about the about your glucose control. It will tell you about your blood pressure. A lot of things could be done through these apps nowadays, and I think we should ourselves first be aware of these apps and make ourselves familiar, and have to then extend that to the patients. And of course, we have ambulatory home blood pressure monitoring. We have continuous glucose monitoring. These things would be helpful. And these patients who have multiple risk factors should be vaccinated against your influenza, pneumococcus, and Harvard zoster. Now, next comes to stage-dependent specific measures. This is the different stages, and I won't go through all of them. But as I've said, lifestyle modification and control of risk factors are vital. And then the rest, and when it comes to the pharmacotherapy, that depends on the stage of the disease and the comorbidities present. You have a lot of things to choose from this pharmacotherapy, but what you're going to choose, this is something you just, you use your brain, and I think you can get the answer. A patient comes with, in stage 1, with the basic, you try diet, exercise and all, it doesn't work, then you think about anti-obesity medications. And you have anti-obesity medications now, especially if this patient has obesity along with some other risk factors, then of course you would need the patient's weight needs to come down. Now, if the patient has hypertriglyceridemia, of course we know that if the primary objective would be to reduce, in patients who are at a high risk, to reduce the LDL. So you increase the statin, and once the LDL level is achieved, and if you still have an elevated triglyceride, then of course you may consider in specific cases eicosapentaenoic acid or maybe fibrates, depending on the triglyceride levels. And then say hypertension. Of course, in hypertension, the main objective would be to treat the level of blood pressure, bring it to the target level. But again, if this patient has proteinuria, say CKD with proteinuria, then you can think about at least giving them herbs or A's. So that's how you do it. And say the patient comes in with a CKD, and the patient has CKD with proteinuria, you think about herbs or A's. If the patient has, or rather with SGLT2 inhibitors, if there is no proteinuria, just CKD, and if the patient has a diabetic nephropathy, then you think about phenylneuron, or even now we know from the flow study, the GLP-1 agonist. And similarly, if the patient has subclinical coronary artery disease, you have done a CT scan, it's a lot of calcium, you give this patient statin, and if the calcium level is very high, say 300 or more, you also add in aspirin. So these are the things you have to do, and the same is true for patients who had LV dysfunction, maybe asymptomatic LV dysfunction, not very uncommon. Patient doesn't have any symptom of heart failure, but the ejection fraction is 40, say, or 45, or even 35. What are you going to do? So we have evidence that in such patients, giving beta blockers and ACE or herbs are helpful. So that's what we can do in such patients. And of course, patients who are very obese and has cardiovascular disease refractory to other medications, you also have bariatric surgery available. Now coming to this stage 4 disease, which is the advanced stage, where the patient has CKD very high, end stage CKD or CVD, very clinical CVD. Here, of course, the treatment is secondary prevention, you all know. Now, although implementation of care in the Indian setting may vary depending on whether it's provided in the primary, secondary or tertiary care or in the public or private hospitals, availability of an Indian practice recommendation may provide a framework to guide physicians to approach patients with CKM syndrome within the limitations of their practice environment and understand when to refer these patients to tertiary care or to the other specialties. And therefore, I think it's very important that we have an Indian-specific guideline on CKM. So to summarize, South Asians are disproportionately affected by cardiometabolic and kidney diseases, often at the lower body weight and younger age, a higher atherosclerotic burden, high prevalence of insulin resistance, metabolic syndrome, hypertriglyceridemia, hypertension, diabetes are characteristic of the South Asian population. Early detection, integrated preventive approach, and targeted interventions are crucial to prevent disease progression. While a common practice recommendation is appreciated, a country-specific approach is necessary. All adults 20 years or more and those with risk factors for CKM should be screened, and although not validated in the population, prevalence score modified by a factor of 1.5 may be used to assess the CV risk till we have a risk factor of our own, till we have a risk calculator of our own. And although the patient may first present very specialty, interdepartmental cross-referrals are usually necessary when the disease has advanced to stage 2 or beyond. So availability of country-specific guidelines are likely to help in implementation of care in the Indian setting. Thank you.
Thank you very much, Subra. I have a couple of questions. Do anybody have questions from the floor before I? Okay, Urmila, you go first.
So thank you, Dr. Banerjee, for enlightening us with a very current topic of importance and where we all should merge upon to share